Channel 1, Sesotho, Setswana, Sepedi, Channel 3, isiZulu and isiXhosa, Channel 4, Afrikaans, Channel 2, Chivenda and Xitsonga, Channel 5. Sign language will be here in front and on TV screen. If you need help, so that your preferred language. So that you are getting this and you can press your own preferred language. Marale arasa. Okay. I'm going to welcome you all and thank you for coming to the meeting. Keep on raising your hand so that you create device your preferred language. You are all welcomed. I'm going to ask honorable members that are sitting with me here to introduce themselves. I've already told you I am Dr. Rebecca Dikhamela, the chairperson of the Health Portfolio Committee in Gauteng. I'm going to ask them to also stand up and introduce themselves to yourselves.
Thank you, Chairperson. Thank you, Chairperson. Good morning, everyone. My name is Honorable Dorothea Khatebe. I'm a member of this Portfolio Committee. Thank you.
Dumelang. Aibo, dumelang. Likai. Reteng, are mamelaneng, re tlo kgona ho sebedisana hantle. Ka lebitso ke Matshidiso Mfikwe, ke leloko la Committee ya Health ko Gauteng Provincial Legislature. Ke a leboha.
Molweni, good morning, sanibonani, dumelang. Igama lami nguMbulelo Bhaga from the National Council of Provinces, representing Gauteng in the Department of Health. Thank you.
Ralebuha, Kiba Rumiwa, Akiri, you elected us in 2019. We are here, business year, the elections. You've got the agenda in your package that you were given. Now, can we adopt this agenda? Opening and welcome, adoption of the agenda, apologies, introduction, presentation, inputs by portfolio committee, oral inputs and submissions, responses to inputs and submissions, and closing remarks. Honorable members, can we adopt this agenda?
Thank you, Chair. Matshidiso Mfikwe, honorable member. I move for adoption of the agenda. Thank you.
Seconder.
Thank you, Chair. Honorable Khatebe, I second the agenda.
Thank you very much. If we continue to talk among ourselves, the noise is coming in front and we do not hear you. Item 3 is apologies. I've got some apologies. One for Honorable Litsie. She is held up and she won't be with us. I'm also having an apology for the MEC for Health in Gauteng, Honorable Nomantu Komora Lehuku. She's not going to be with us. I am now going to also, while I'm doing apologies, ask the committee coordinators to introduce themselves, and we will also introduce the Gauteng leadership so that they tell us who they are with here.
Thank you, Chair. Sanbonani Ikamala Munogwazi Ngidi, Senior Coordinator of Portfolio Committee.
Can I also ask the legal person who is accompanying the committee to introduce herself?
Dumelang. Dumelang. Lebitso la ka ke Musimo Rakekana. I'm the legal advisor for the committee. Thank you.
Kabela. Lebitso la ka ke Maggie Mokonoto, ke researcher portfolio committee on health. Ke a leboga.
Dumelang. Ka lebitso ke Lentswe Mothobi, Public Participation Coordinator in the Gauteng Legislature.
Thank you very much. Can I ask the representative from the Gauteng Department of Health to tell us who is accompanying him today?
Dumela, nna ke Molefi Mosenori, ke NHI coordinator mo Department of Health. Rena mo le our acting COO, Ntate Magoro, Terence Magoro, and then only but I introduce her from that side, from this side, Basi Diben district. And then the Professor Mosa. Can you introduce yourself, please?
Where is Isaac? Where is Isaac?
Dumelang, nna ke Disebo Pepenene, Acting Director in Sedibeng District Health Services.
Dumelang batho beso. Okay, ke nna Makibiti Madolo, ke nna Acting Chief Director, Sedibeng District Health Services. Ke a leboha.
Dumelang batswadi, nna ke Kenneth Sijeng, ke Acting CEO ya Sebokeng Hospital.
Dumelang, Shabir Musa, Professor Musa, Coordinator CUP in Johannesburg, NHI CUP.
Dumelang bagolo, lebitso la ka ke Tsebo Diteko, Acting CEO, Dr. Yusuf Dadu Hospital. Thanks.
Dumelang, ka lebitso ke Canada Masaneng, ke Chief Director, District Health Services, Province.
Re a leboha. According to our program, we are now moving to item 5. The representative from the Department of Health nationally will introduce themselves. We are here to listen to the Department of Health and the NCOP telling us about the National Health Insurance. Can we please take out our pens so that we write, and we are going to make contributions and inputs and questions. Hello? Hello? Can we keep quiet, please? Can we keep quiet? Or noise if it's from outside, can we tell people outside to keep quiet? Because we must achieve what we are here for. If there is noise outside, can we tell people outside to keep quiet? The Portfolio Committee of Health in Gauteng brought the NCOP and the National Department of Health to give you an opportunity to make inputs towards the National Health Insurance. It's very important for all of us to listen and understand what this National Health Insurance is all about. We don't want to see people whose medical aid are finished in July and they've got nowhere to go. Let us pay more attention and listen that this bill is when it is an act, we are all going to benefit. Can I ask the National Department of Health, introduce yourself and start with the presentation, please.
Thank you, Chair. Thank you, Chair. My name is Michael Moabelo from the National Department of Health. I'm Director responsible
drafting,
Mara ke utlwisile, wa itse ba
accompanied by my two colleagues. Ntombi Mnyikiso is a legislative drafter. Okay, and Abigail Baloi is a deputy director, legal services. I am going to ask my colleague from Gauteng to present the presentation that he prepared, and then thereafter I will fill in where there are gaps. Because but from the national point of view, we thought that we discussed quickly and said maybe it is better if we present the Gauteng prepared presentation so that it can talk to the province, it can talk to the needs, to the health needs of the province, and then I'll come up with the national if there are any gap that needs to be filled. Otherwise, I will assist with answers to the questions that the House may ask after the two presentations are done. I'm going to ask my colleague to start summarizing the bill. I believe the bill is part of your package. He's not going to do section clause 1, this one, clause 2, this. He will do the global presentation on the bill. And then while you are at home, you can still go through the bill and read and go on to now details per clause. And I believe, Madam Chair, there is a deadline and there will be an email where you can send your further inputs after this today. Thank you.
Dumela, ke tla dira this presentation mara ke tla e khutsufatsa so that everybody can understand where we are. It was prepared by the Department of Health, Gauteng Department. Santla is just to give a high-level assessment for a NHI. The introduction of NHI, how is it going to affect the population of Gauteng, as well as the work that needs to be done. Definition of NHI. NHI is a health financing system that pulls funds together to ensure that there's access of health for everyone in the community. It means NHI will pull all the funds that I have to do with health service delivery together into one pool so that all South Africans, whether poor or rich, whether living in the suburbs or in the rural areas, they are all able to access health, Habatoka health at that time, without paying any cent at the point of delivery. NHI, once it is introduced, it's going to mean a massive reorganization of the way we deliver health services. It means both private and public health services will be transformed so that they are able to cater for every person in South Africa who qualifies to receive health. Why fully important to NHI? At the moment, currently, we have two systems of health service delivery. If only onale chelete or obereka onale medical aid, you are able to access health through private care. Ukona go ya ko net care, o ya ko life, o ya ko Mediclinic, unsa card ya gago ya medical aid, and then you are treated. But those who do not have medical aid, they have to come to public hospitals. Public hospitals, we talk about Sebokeng, we talk about Leratong Hospital, Rubuaka Kopanong Hospital. And the problem with the private sector is that you can't go there without money. But you can only come to public sector when you don't have money. because then we are able to be treated. So this diagram is the discrepancies between the private health sector and the public health sector. So we don't want to continue with these discrepancies, the differences between public and private. We want to have one tier system of health service delivery, no longer fragmented. We have a framework. The NHI bill, before it becomes an act, it wants to say a framework, what is going to happen. The first thing is that we have central hospitals. What we call quaternary services, like Chris Hani Baragwanath, like Charlotte Macrae Hospital, Steve Biko Academic Hospital, and George Mukar Mohauti. Those are, we call them central hospitals. For you to go there is because you are referred either by regional hospital, like Woleratu, or you are referred by district hospitals to go there for a complicated operation. Those are the public hospitals. So in terms of the bill, that is going to change because we call them national entities, these hospitals, because they serve not only Gauteng, they serve all other provinces. Or Charlotte Macrae or Steve Biko. But Baba Twanko Limpopo Bate, because they are referred there also. So they are national entities, so they need to serve everybody, not only Gauteng patients. But you need to be referred to those hospitals. You can't just go Kamaudo, Wareke, hospital, so they are going to be autonomous and controlled by central hospital services. They are going to be controlled by national. Then the second change, it will be what we call district health management office. District more health. They run services in each district. Sidibay Enale district office yating, Johannesburg Metro Enale office yating. So those services, they are running all the primary health care services and also district hospitals and regional hospitals. They are going to be called district health management office in terms of the act. And they are going to be responsible for delivery of services. What is going to be different is that they are going to be providers of services rather than purchasers of services. NHI Fund will be the purchaser of services. So what is going to be important is that every clinic, every community health center, every hospital, and every GP who provide the service are going to have to be registered under National Health Fund. They will be accredited to provide services. So how you go, whether it's private or public, you don't pay at that point of service. But National Health Fund will pay the necessary fee to the providers of those services. If the GP will provide those services. So the change is that we are going to introduce what we call health information system. We introduce in our facilities where we put you into a data, we give you a number, an identification number, we register you in that particular facility. So even when you come repeatedly, we'll just press the computer, your name will appear. Last month, you had your treatment, your chronic medicine, if you are a chronic patient, and then you are given treatment at that particular time. And then the information is transferred also to the National Health Insurance Fund so that they can provide payout to the provider. Then there are services that are going to still remain provincial authority. The services that are going to be provincial authority will be regional hospitals. Wolerato, Mbosebukeng, they will still be run under the stewardship of the provincial department. But what has changed is that MEC now is not only going to be responsible for public facilities, it will also be responsible for private facilities in that particular area, in that particular province. So his job will be much more inclusive because we will not have a separate services for public and for private facilities. I'm just summarizing again. And then EMS will remain the same, but will ensure that private and public also merge to have an EMS service so that you don't have to pay the provider. NHI fund will pay the provider. So basically, that's the difference in terms of what is going to happen. But there's going to be a lot of work that is being undertaken. At the moment, what has happened is that the bill has been approved by National Assembly. It's now being discussed at the NCOP, where the provinces are involved. That's why we are coming here to ask for your views in terms of the NHI, so that the representatives of the province at NCOP will be able to bring your views that you are going to get here, so that they are able to discuss and debate those issues at NCOP. And once NCOP has heard all the inputs, whether written or what you are going to say today, they are going to debate and then they put the bill to a vote. And once the NCOP has adopted the bill, then it will be signed, sent to the president for his signature. I think that's the summary in terms of what I wanted to represent.
Thank you very much, the province, for that input. This machine, in a little tracker, let's leave it here. We mustn't go out with it because then you will attract police. Please, let's leave it here at the end of the meeting so that we don't find ourselves in trouble. Thank you. Proceed.
Okay, thank you. I am now going to present the bill as presented to the National Council of Provinces. You know, the South African legislative process is very long and is very interactive, is very inclusive. We differentiate between many bills. We have Section 74 bill, Section 75 bill, Section 76 and 77. This one is Section 76 bill. Section 76 bills are ordinary bills that are affecting provinces. Those are the bills that must go to NCOP from the National Assembly. Once the bill is passed by the National Assembly, it doesn't go to the president, it goes to NCOP. NCOP is the second house of parliament where provinces are presented. I think there's 90 members. And in that house, the permanent delegates who are in Cape Town and then will come to the province to present the bill as passed by the National Assembly to come and seek what we call a provincial mandate. Meaning, after the public hearings in Gauteng, the permanent delegate will be given a mandate by the Gauteng legislature to go to NCOP with other 8 provinces to say, from Gauteng, This is our mandate. The people of Gauteng, they like the bill, they like the bill, but they want you to change here and there, and then they will then present that to the NCOP as a house. If the NCOP accept the changes, the proposal made by various provinces, then the bill will not go to the president. It must go back to the National Assembly for what we call in law concurrence. And if there's concurrence, then the bill will be sent to the president to sign into law. Then it will be called the National Health Insurance Act. And then it will be implemented. So we are now in stage 2 of the legislative process, where the bill is being approved by the National Assembly. The 400 members approved it. Now it must go to NCOP, but NCOP does not approve the bill. They vote. They must get mandate from each province. We are going around provinces now to do what we are doing today, so that each province will go to NCOP and present their mandate. So the NHI bill, its main purpose is to create a fund that will be called the NHI fund. The fund is going to be responsible for, amongst others, to pay for your treatment. If you go to a hospital, to a doctor, to a pharmacy, you are not going to pay. The same way when somebody has a medical aid, goes to a hospital, then the medical aid will pay for the services rendered. So NHI is, in simple language, the medical aid for everyone. But you are not going to contribute. It is going to contribute. The contribution will come from the national fiscal as determined by the Minister of Finance. Okay. As I've already indicated, the purpose of the bill is to create the National Health Insurance Fund. That is the pooling of resources into one fund that will be responsible to pay for the services of everyone in the country. Of course, there will be some exceptions, but it is a public it's a public medical aid for everyone. Okay. Yeah, I've already indicated that is to establish and maintain the National Health Insurance Fund in the Republic, funded through mandatory prepayment, meaning there will be prepayment to the fund. The fund is not going to get money after. It must get the money before. So it will be funded through state resources. Then that fund will be then used to pay for services, for treatment at the point of service. Okay, the Act will apply to all health establishment. Health establishment is a place where you get treated, like your hospital is a health establishment, a clinic, community health center, a pharmacy. Those are what we call in the National Health Act health establishment. So they differ. My colleague has indicated that we have central hospitals, which are called national entities, because the board that governed the central hospital is appointed by the minister. But the board for regional hospitals and others are appointed by the MECs. But the minister can delegate the powers to appoint the board of central hospital to the MEC. It is going to cover everyone. That is why it is called universal health coverage. Universal means everyone. So it is the NHI is there for every citizen, and for foreigners who are in South Africa. But for foreigners, there's a certain limitation that the bill set for their treatment in hospitals. And everyone must register. You must register so that for planning purposes, so that we will know that in Gauteng, in this area, in this district, there are this many people who may need to access health care services. So everyone will be registered, but children who are born will be registered automatically at birth. But us will have to register when the NHI is implemented in the next few years. Okay. The service providers must be registered. They must be registered and also be accredited to meet norms and standards. We have the Office of the Health Standard Compliance that is going to go and assess whether a health establishment meets the requirement. If that meets the requirement, it is going to be registered on the NHI system as a service care provider, so that if you go to that provider, your bill will be paid by the NHI fund. Okay, I've already indicated that the fund is going to be what we call Schedule 3A entity of Public Service of Public Finance Management Act. It is called Schedule 3A public entity because it is going to be governed by the board. The board is going to be appointed by the minister with the approval of cabinet. Okay. As I've already indicated that minister is going to appoint the board with the approval of cabinet, then the board is, amongst others, will be responsible for appointing the chief executive officer, who will be the administrative head of NHI. There will be committees that will be established in terms of the act. There will be several committees that will be established to assist in the governance of NHI funds. There will also be the advisory committees or various committees that the minister is going to appoint to advise him on certain aspects. For example, it will be, there can be a pricing committee, a pricing advisory committee. That will be the committee that will do research in terms of pricing and advise the minister in the determination of the prices to be paid to service providers. That will be in consultation with the Minister of Finance because it involves financial matters. The provinces will still play a role. Remember, the regional hospitals will still be under the auspices of the provinces. Even the central hospitals, although there will be central entities, national entities, but they will still be in certain provinces. As we currently have, I think we have around 10 central hospitals. We have 4, I think, in Gauteng and 2 in Western Cape and 2 in KZN. Okay. Because NHI fund is going to provide services, there will be complaints. So the NHI Act provides for a system where you can lodge complaints. For example, if the NHI fund refuses to pay for your treatment, because NHI, although it's going to pay for your treatment, there are certain treatment that will not be paid for. For example, selective. If somebody want to, for example, do the skin crafts, that is not clinically necessary, the NHI fund will not pay. So for those kind of cases, you will then be able to lodge a complaint to say, my bill was not paid, and these are the services that were rendered to me by this particular service provider that is also accredited and registered. Okay, financial matters, where will the money for NHI come from? Where will it come from? It will normally come from the appropriation by Parliament. It will also come from the general tax, the medical scheme tax, credit, payroll tax, surcharge on personal income tax. There is a possibility that the general income tax may be affected as a result of the budget of the NHI. So these matters of financial determination will be done in consultation with the Minister of Finance. Okay, of course, the Act grants the Minister the powers to delegate certain powers to provinces and also to the fund, and also within the fund itself there will be those delegation and assignment of duties between officials and the fund. This bill, because it's going to usher in a concept called universal health coverage. it therefore affects various legislations. And because of that, we have added a schedule at the end of the bill where we indicate the acts that are going to be amended and the extent to which they are amended. Amongst the acts that will be amended will be the Medicine and Registered Substances Act, for example, the National Health Act, the Nursing Act, the Traditional Health Practitioners Act, the Occupational Health in Mines Act, for example. They will be affected as far as they relate to the provision of health care services. For example, the Occupational Mines Act provides that if a miner wants to claim for occupational disease, he must submit himself to a doctor and then pay for that examination. In terms of NHI Act, that because it's regarded as a health service, it will be covered by NHI fund and then it will therefore be paid. That's why there is an amendment to that in that act to remove the payment directly by the person receiving treatment. So there are a lot of them that are amended currently and that will be amended after the NHI is implemented. Okay, the NHI will be implemented in phases. The penultimate clause, it says implementation in phases. It is 2023 to 2026, 2026 to 2029, meaning it will be implemented over a period of time because there are many things that must happen before we can fully implement the NHI. One of the most important one is accreditation of service providers. And service providers must meet norms and standards as determined by the Office of the Health Standard Compliance. Because of that, it may take a little bit longer for many health establishments to meet the standards to be accredited and be registered to provide healthcare services under the NHI. I think I've come to the end of my short presentation, Chair. Thank you very much.
Thank you very much for the presentation about the NHI from the Department of Health. I think he was audible. We were able to hear what is the input all about. Rialebuha for this presentation, and also thank you to the Department of Health in Gauteng for highlighting how far you are and the process you will be following going forward. Kanselo Sinyanako, I will ask the Honorable, we are only 2-3, but I'll ask Honorable Mfikwe to also make few remarks based on the presentation that we have received today.
Thank you, Chair. Ke dumedise hape. Dumelang batho ba Vadi. A go lutlu ka ra leo, mala thabela re teng. Dumelang. Re a leboha. No, Chair. Government ya batho e ikemiseditse ho tlisa ditshebeletso tsa batho setjhabeng haufi le setjhaba. NHI ke tsela e government e batlang ho tlisa ditshebeletso tsa setjhaba tsa health ho batho bohle ba tlameileng ba di fumane, ho batho bohle ba nang le tokelo ya ho fumana tshebeletso tsa bophelo. Ho sa kgathalatsehe hore re na le tjhelete kapa ha re na tjhelete. Eba system e tlo tlisang ditshebeletso including funding e tswang go government hore kaofela re di nirang ditshebeletso tseo ka nako le motsotso re kgone hore re di fumane ho sena hore mang o na le eng mang hana eng. E tla etsa hore re kgone ho thola ditshebeletso tseo re di hlokang ka nako eo re di hlokang moo re di hlokang ko teng. Batho ba tlo e fumanang tshebeletso kapa funding ya national healthcare ke batho ba dulang mo country ya rona kaofela ba hore reng ha ba kgone ho kenella ditshebeletso tse leng hore di medical aid ha e kgone ho di etsa. Re batla hore tjhelete e funding ya tsona kaofela e kenywe into one pool where everybody will have access to it and healthcare through just a presentation of your own ID. Ho ska ba lo ho bile le discrimination hobane nna ke le matshediso ke sena tjhelete kapa ke sena ho kgona ho kena ko sepetleleng. Re aware hore constitution ya rona e fa batho ba rona a right to healthcare. So that is what we're trying to do ka the national health insurance. Re utlwelana le setjhaba. Re etsetsa hore ditshebeletso tsa health re di fumane ka ho lekana re le community kapa setjhaba sa country ya rona. Also, to make sure that health becomes a public good for our communities and all the people that needs a proper health care. Re tloetsa hore through the insurance, affordability ya service e o e hlokang o le motho needang healthcare ebe hore e bo haufinyana le hore service o tlo e fumanang ebe efficient ebe effective as well. So that is why we are here to say to all of our people that are going to need healthcare, this is a right bill that will make sure that none of us is discriminated. Ha re fihla ditleliniking tsa rona kapa ha re fihla dipetleleng tsa rona. That is why re really government ya batho re tlisa ho lona hore ha re utlwisiseng re kope hape hore a re supporteng hobane ha e lo re discriminate kaofela ha rona through the insurance. We will benefit, we will get the proper health care, a professional, a efficient, effective. So really mkhato ra supporta re tlisitse ho lona re a re inkeng re kope government hore e re implementele yona hore ha re kena ditleliniking le dipetlele tsa rona re kgone ho fumana service e re tsebang hore re tshwanetse hore re fumane. Ke a leboha tjhe.
Can I also recognize Honorable Khatebe to make questions or inputs?
Thank you, Chairperson. Let me also welcome the presentation from the department. Chairperson, mine is only the clarity seeking questions from Tate Musenoch. I don't know whether you are allowing me to do that. Okay, thank you, Chairperson. Tate Musenoch, on your presentation, we say this National Health Insurance Fund, it will be available to go dipetlele. So my question is, it will be available to dipetlele tsa rona kaofela na? And highly available to dipetlele tsa rona kaofela. If ke le Granny wa ha Khatebe and I'm not registered under this fund, ke kule ke ya sepetlele, ke tlo kgona na ho thuseha ke ntse ke se under yona this fund na? And then you also said it involves the private hospitals. Ha ke lo admitwa ko private hospitals, let me say ke limala ke le around Medicenter or Netcare, it is going to pay admission yaka le ya ho robala sepetlele na? This funding at least one national la bang admita ko private e tlo patala that process yaka mo ke dutsing ko sepetlele na? Ke yona question yaka eo. And then if o re e tlo choose dipetlele tsa rona tsa government, it won't be ko dipetlele kaofela. Why? Because dipetlele tseo di under government kaofela tsona. Ke a leboha. Thank you so much.
Ra leboha Honorable Khatebe. Halala Western halala. Halala Western halala. Halala Sidibeng halala. Halala, Sidibeng, halala. Thank you for coming so that you also come and make contributions to the NHI bill. Now, inako ya lena to come lilina li raise your concerns, and if you support, you can just say yeah, na I support. But if unali the issues, raise them here. They are here to come and help you and answer your questions. Agora arisanya medical aid wa fela ka September, ka October we use money from the house and arisana di jogo haya ker. Yeah. Now, baba nali interesting ya ore ba raise the question emisa matsogo ke tla starta kam ke tla boya kam. Qualify the number, and if our raise it now, ulibale, because the number ki the number ker, numbers are numbering. The team is going to start komuraho ban to say verify the number. Aringa ki brainwave ya ker. Yeah. Isaac Ili Wakile, please go to the back. I will start from the back, coming this side. So that only one, only two. I want 2.1, only 2.2. Ne, please get the back. MLA lang to the number so that Kelly won. Can you please stand up? Then I can see you from the back. Number one. All right, kamung rao, emisam matso. Yes, number one. Sorry, can I use maybe Kiriwa bearing something in black on the head? You are number one. Dula fasi ma'am. Number two is your neighbor, ka green. Yes, two. Again. Number three, ka black. Sit down, sir. With number three. And then the number four. Four, yes, four. Yes, four. Five, yes, sit down. Five. Six, sit down. Seven. Kimo wena ese. The se. Mutlomper wena. Ki seven again. Kitaya kwa. Wena seven. 7. 8. Kitabuya hulina. 8. Ye more wakile, more official, let me tell you to number 8. Where Nase? Wakile, ask him to put the hand down. Yes. Number 8, sir. Sit down. Yes, 8. 9. 10. Green. One green is 9 and 10, sir. The two of you, 10. MLN. 11. 12. 13, 14, 13, 14, the two of you. And then 14, yes, yes, 14, 14. I mean 15, yes, 15. 16, 17, 18, 18, sir, 18, 19, 19. Everyone captured their number come. 19 and a little 19. Little bulela straight to the point. 19 is you say. Come on, we are done. Arten come. My sister, sit down for now. Yakom raho akile. Oh, let's start this side, or let's start that side. Yeah, it's fine because you are already there. Number 1, sit down. Sorry, Emelang happy okari, you are confusing. Emelang, number 1 at the back. 1, 2, yes, 3, 4, 5, 5. By 5, yes. My sister can blue, ki number 5. Powder blue, yes. And then number 6. Sit down, ma'am. 7. Emelela Wood, number 7. When? Yes. 8, my sister. And then in 9, ma'am, 9. And then 10, ma'am, with number 10. Where? Now 10. 11, my sister. Yeah, with number 11. Akere ki bala ka morago ke tla ka mo. Number 12, go staging. Number 13. Number 14, number 15. Le capture the number. 15. Camera was taking you pictures. Please don't steal other people's numbers. I know you are good behaving. You are not going to say number 4, who's number 4. If our emission is all go for last chance. If you didn't raise your hand, this side, go for last chance. If our emission is over this side, go for last chance. So, una join our number 20 this side, ne? 21. Going, gone. Ile, train come. Come on. 16, down. 17, down. Going, gone. No more hands. Stakeholders that are here, you are allowed to go and write your written submissions and you can bring them to us here on the table. Alternatively, you can send them to ngidi@gpl.gov.za or naugust@gpl.gov.za. Remember the closing date, Kidi 4 October for bill contributions. Agree? Ra understand again? So now, Ratom. Number 1, emelela, make your input ka language ye o e ratang. Oh, itang ka mo, ba botlhe ba ka mo, le tle le kgone go bolela because e le mo re tlo kgona go capture nicely your input. Itang ka mo morong ela le kgone go bolela so that we capture everything. La bona hore e bereke ga monate bjang. Yebo. Bile a hone go ka se be le 2.2 le 3.3 akere. Yeah. Re tlile mo go kry di inputs. Yeah. Isaac, e tla o tlo o ba fe mic from number 1. Ge tla ka mo, we are going to do the same. The stakeholders, you continue to submit your input to the email address that I have mentioned. If you have missed it, come to us on the table so that we receive your submissions. We are grateful you came. I remain line so that the risk commotion. Agree? Among line. Kamola, if you have a challenge your healthy, let us know so that the risk are for a long time. Can all those who want to contribute, babo baba nyaka go bolela, emelelang ka ro, and then le khone go bolela. Ge o ema mola o re ke nna Rebecca Digamela from the GPL, ke tlile mo go bolela ka Billy, wa ke re nna ke re from the GPL. Wena o tla bolela gore o tswa kae, ke wena wa efe organization, so that re kgone go bona gore ke bo mang ba batlileng ka mo go bili, and your contributions ro di capture a re ilo di latla because re nyaka gore bili e go bonagale gore go bile le public participation. Akere, number one, you are welcome, ma'am. Thank you.
Ke a leboga program director, ke dumedise committee ya rona from parliament, le from province legislature ya rona, re dumedise baagi ba Sedibeng, le baagi ba Westland. Westland le yone e teng mo gae, nna ke me Mama Tuane from Rand West, Thembi Matuani from PEC member ya ANC Women's League. Nna ke tlo leboga presentation ya ka Jeko, yone ruri kgale re emetse gore ka Jeko ebe e le gore re bua ka gore e approvilwe go fetswe e kgone go implementiwa. Billy ena ya NHS, NHI, ito thusa especially our poor people. Batho ba rona ba bangata ke ba ba senang di medical, ba ba sotlegang. Mme ga re na le yone NHI ena e tlo kgonang gore e duelle batho ba rona ba ba sa kgoneng. Ke go bontsha gore puso ena e a re kgatalla, e kgatalla batho ba rona ba ba sa kgoneng. Nna ke opela matsogo ka re a ye pele e approve batho ba rona ba ba lwalang, ba bang ba lwala go fitlhela ba tlhokafala gonne di-queue di dingata ko di-privateng ga ba kgone go kena. Yaanong ba tla kgona go kena ko private hospitals ba kgone go duelelwa ke NHI bill ena. Ke a leboga go menagane.
Number two.
Ke a go dumedisa motsamaiso tirelo ya Kajeko le di honorable MPs tse o na le tsona. Ka lebitso ke nna Ana Setswalo Moja, ke tswa ko extension 12 Kagiso Ward 4. Te tla gatella mo mantsweng a mme Matuane. Go bua nnete chairperson, 2007 until now, it's long. Re ntse re bina pina tshweng. Can we please now raise a show gore that pina tshweng a re sa e bina, re kopa gore le tsamaye lo go implementa molao o gobane o tlo benefita batho ba dikobo dikhutshwane. Ke bua yana gobane mme wa ka ke sefofu ka Jeko itse ga ke mo isa ko doctor gore a ye go konomakiwa leitlho la gagwe ba mpatla 22,000 for one eye. So ga tsang ke ka kgona go mofa a health e leng gore e tla gore tsa gore a ba ka Jeko be ke re ga se sefofu mara ka Jeko ke sefofu. So this medical aid fund it tlo thusa batho ba go tshwana le bomme ba rona bonkgono ba rona ba leng gore bana ba bone ba koropa mara ha ba kgone go patala di medical aid tsa go tlhokomela batsadi ba bone. But suggestion e ke beang tafoleng ke gore na ono ka re human resources at this fund must be paid by the department, not by the fund itself. Because haribate ka usane hote the salary di fedile because it's been depleted by paying the salaries tsa batho ba ka ba bereka mo. My suggestion is let all who will be going to be implement to oversee this fund must be paid through the Department of Health. Ke a leboga.
Thank you. Number 3.
Ke a leboga motsamaisi mo le tapfule e hlomphehileng. Nna ke le Emmanuel Ponyane ke a tlatsa taba ya bili hore e tsama e fete e ke ipase empa ke na le di clarity tse ke di kopang hore ka di fumana ke utlwile presenter mona a bua ka hore you should be registered. Nka thuswa mono hore na kapo hona le batlatla ho rona di official tse tlatla ho rona hore re tle re tsebe ho ba registered re ba le that number. The other thing o buile ka hore hona le mo hong mo fund ena e sa tlo cover in terms ya di private. The information ene re tluile before le tlo hlalosa ka o teba ene re tluile re utlwile ene ka re the private thing, we are still going to be covered. Ke kopa fela clarity ya ka moo. Empa ha ile hore bill e tswelle, ke a e kgothaletsa, ke phahamisa letsoho ho yona hobane e tlo thusa setjhaba se sengata. Ba bang ke hopola warding ya ka, Ward 16 mane Rasteval informal settlement. There was a lady, Anna Dutika Tlung, for a very long time, for years, more than 4 years, Dutika Tlung, as in a wheelchair. We even talked to the social department, but assist we taught only how to advice from one of medical helpers, tse sebetsang di petleleng tse haufinyana mona le rona, hore ya spetlele se itseng o tla fumana wheelchair mo. Ke ha ile hona a thuseya. E sale re ene re emetse department ya social health, social welfare, hore ba tle ba tlo assista mme ba ne ba le teng ba supplier the food parcel. Mme o a sa kgone ho thuseya ba na dutse ka tlung. Fortunate ne re tseba ka yena jwalo ka o mong wa di committee tse teng ka hara motse. Re le ra ba isa ntlong eo a kgona ho thuseya, empa o stragetse haholo in terms ya ho thola stulo se tsamayang. Fela fund eo ke motho a kulang. Re na le bona ka hara ward bo re tshwantseng hore di official di kopane le rona, re ba bontshe hore ke kae le kae mo ho nang le di struggle tsa batho ba sa kgoneng ho fihlella dithuso tsena fund e tla fana ka tsona. Ke a leboha.
Number 4.
Dumelang. Lina la ka ke Bolokang Montwedi. I am from the Provincial Office of DINOSA, Democratic Nursing Organization of South Africa. I've got clarity-seeking questions. Number 1, currently we are experiencing brain drain in South Africa in terms of our health professionals. Recently, in Ekurhuleni, 200 nurses left the department. What is in place from the government to retain our practitioners, both doctors, nurses, physiotherapists, everybody who's in the Department of Health? Number 2, in the presentation there was a mention of accreditation. What are the requirements for facilities to be accredited? And when I say facilities, I mean from hospital until to the clinic. We are currently sitting at the clinic in Gauteng that are containers. They don't even meet the standard ideal clinic. And then we want to implement the NHI. What about the infrastructure? Why are we not starting with the infrastructure and the human resource? Number 3, currently the department does not have a retainment policy. As and when people resign, they go. The department cannot compete with any other private company that is recruiting health professionals. Why are we not having such a policy? Why are we letting practitioners leave the department? Then who's going to work in those facilities when we implement the NHI? The other one is the facilities. Which facilities are identified currently where the rollout can be, what's the word? Mobile Zama Moteng. Yeah, piloting. Which facilities within Gauteng? We would like to know so that we can give support to those facilities. The presentation talked to the health information system. We are currently sitting with facilities that does not even have Wi-Fi. The institutions, the hospitals, the clinics, there's no Wi-Fi. So that system is not even integrated throughout the province. When will that happen? There's nothing wrong with the bill, but the implementation part of it has got problems. We are on the grounds and we see these problems. The other one is that of, this is public consultation. but then practitioners, where they consulted, the doctors, the nurses, the physiotherapists, where they consulted, the people who must render the service. What is their position in terms of NHI? Lastly, practitioners need to register. For a service to be provided or to be rendered, you need practitioners and support staff. Is support staff supposed to register also, or only health professionals need to register? Thank you.
Number 5.
Dumelang, ke Sabata Tekiso from Dinosa as well. I'm the regional chair in Sidibeng. So I'm going to continue from where my colleague has just left. We've supported NHI since the former National Minister of Health, Dr. Aaron Motsoaledi, was so passionately discussing it, and we adopted it long ago. We are surprised why we are still having public gatherings even now. So according to us, this was supposed to have long been implemented so that our people can benefit from it. But however, we also need to make sure that after implementing this, or before even implementing this, our people don't eat tablets and medical devices. Our people need employment, our people need housing, our people need conditions so that they are able to prevent diseases even before they start. So we cannot overemphasize on those things, because as a nurse manager, where I'm working, we are admitting a lot of patients who are coming in from diseases that are preventable. So there was a concept of primary re-engineering, preventing diseases instead of being curative. So please, let us also look at that. And as we implement this NHI, have consultations like my colleague have said, nurses and doctors. There are a lot of nurses who are unemployed, yet we have so many people who are also sick, who cannot access healthcare, and who needs to be serviced. So big ups to this platform, but please, as you go to National Assembly, we don't want to have a talk shop like we had with the land expropriation without compensation, which was bungled at the National Assembly. Thank you very much.
Thank you. Number 6.
Sanbonan.
Yebo.
My name is Mdeni Madondo. I'm the Deputy Regional Chair of Dinosa. I'm going to continue where my colleagues left off. Firstly, I would like to thank the Chair for this presentation. And secondly, as Dinosa, we are seeking accountability. If this NHI bill can go hand in hand with the legal department. Why am I saying that? I work in Kopanong Hospital. In Kopanong Hospital, we do have an unfinished infrastructure that was meant for COVID. The structure is worth plus minus 187 million. That is what we were told as organized labor in the meeting. Right now, we do have an influx of patients. Sometimes in our casualty, we do have plus minus 20 patients that are waiting for beds. Yes, this bill is nicely, when it's said administratively so, but the reality of the true matter is that, are we ready in our infrastructure? For instance, in Sidibeng, there's only 2 hospitals. We do have Kopanong, that is level 1, and Sibukeng. In the past few years, nothing has been built that to accommodate the growing population in this region. So for us as Dinosa, we are really concerned about this. It's our people that are suffering. I might be a nurse, but when I go out of the institution, I'm a community member. I do have families that seek to utilize this infrastructure. If we are going to talk nice things administratively, so what about the infrastructure? That, for instance, like right now, even the infrastructure that we have, they are not in good conditions. Even those contractors that are appointed, they are not doing a good job. So for us, Chairperson, can we, especially here in Gauteng province, because this is not the only institution that was supposed to assist with COVID, but there is another one that is more than that in terms of financial implication. So can we have accountability for those who won't be doing their part? Thank you.
Thank you. Number 7.
Dumelang. Lebitso la ka ke Tom Kombelayo, Nehau Sidibeng Regional Deputy Secretary. The chairperson, as Nehau, re-acknowledge the presentation. Why re-acknowledge the presentation? Because presentation ya Department of Health, it's a melana handle. Liseo Nehau is a proposing ya se bear on the table. How no buaga the purpose of the bill? Ubuaga, what is the NHI? Lead the status of the NHI. Hagno buaga tsona ba no so buile ka tsona. Ke tla submita the input ya Nehau SCDBeng ha ke kata mona, but hona jwale the reason se ke batla go fana ka tsona why re dumelana le NHI. Mabaka ke ana a latelang, ke tla bua ka fela ka A9. Nehau believes that the NHI is progressive policy towards addressing the healthcare center crisis that the country is faced with. The two-tiered healthcare system, which is constitutes the private and the public health sector, is on the verge of collapsing. The private health is characterized by high cost of care, which made its access only limited to a few that could afford it. On the other end, we have a public health sector that is under resources and overcrowded, as it has to cater for the majority of population that cannot afford the private health care. While we are trying to build a more equal society, health is very unequal. The amount spent on the health care of each person with medical aid is 5 times the amount that is spent on each person who relies entirely on public health facilities. If the country continues with the existing health care system that is discriminate based on the person's socio-economic status, there will be no progress in addressing the quadruple burden of disease the country is faced with. Nehau supported the NHI because we want a healthcare system that is fair and equal. It is through the policies such as NHI and South Africa can be able to address the structural inequalities which have put majority of South Africans in entire situations, which includes issues of access to the quality of healthcare. Thank you.
Thank you. Number 8.
Khotsong, lebitso la ka ke Diphapang Jacob Tshwane, ke tswa Ward 1 kwa ya Mfuleni. Na ke tlile mona as a member of the public. So ke re as a member of the public, ke a idumela, ke chaela monwana. Ke chaela monwana ka mabaka a latelang. Ke na le understanding ya system e sebetsang ko country ya rona. Ho nona le taba tsa di Alma Ata declarations. Batho ba tshwanetse ba implement di Alma Ata declarations, ba tshwanetse ba implement. Ke rona di public servants. But I don't think we are well equipped or well knowledgeable about Alma Ata declarations. And then also arising from Ottawa Charter, because here we are talking about primary health care. That is why there was this re-engineering, who but to understand as public servants, or let me say public healthcare workers, to understand their core mandate about their health services in South Africa. And then I believe there's no better animal in this farm. The private is not better than the public. They are all healthcare. But most unfortunately, private is a bit akabaka la chelete. Joale chelete in a hurry hopulin, or the very same private, it gets accredited by the same province. And then it gets subsidized for it to work. And what is happening, more allocation of money is spent towards private healthcare as compared to the public healthcare. And they make more money because they've got medical aids. And medical aid is not a guarantee, because you get people that are limited. Let's say I'm suffering from bipolar. I'm just making an example. I need a 6 months observation. Go institutioning. But when Tebeka after 21 days because my funds are depleted, but my treatment has been interrupted, and we say they are the so-called best providers of health services. And then I'll have to go back go public inqual, go qetella treatment aka hore ke kgone ke be hantle akere. Wa nkutlwisisa. Then it is unfair hore re patala kapo ba ba patalang re patala. And on top of that, ha re thole value for money ka di private. Nothing else. Ke ntwe ba etsang fela ke courtesy, wa bo, but we are there because good will to Department of Health is saying I'll serve with a smile. Ke batla bona smile se ha ke ya ko, because ke ona fela ntwe etsang hore ba be better go feta rona, because they serve with a smile, we don't serve with a smile. Thank you. Phambili.
Number 9.
Thank you. Thank you so much. All protocols observed. I'm Dr. Mhlenge Ncube from the South African Medical Association. So when I've gone through the NHI bill,
Hello, sorry,
Oh,
Doc.
okay.
Just Hanyan. Can we please give him an ear? Let us not talk when he is also talking, because we want to get his inputs so that the responses that are coming later are responding to what he has been, what he would have asked. Please, let's be quiet. If you want to speak or you want to answer a phone, just go outside and come back quietly. Thank you. Proceed, number 9, Doctor.
Yes, thank you so much. So I've gone through the bill, I've listened to the presentations, we've also been in the hospitals. We are also part of the community as doctors, and one of the things that I would really like to highlight is that being part of the community, it is sad to see the difficulties that patients and our communities are facing out there. It is sad for a doctor to have to tell a patient that I could otherwise have saved your life, but I can't because the resources are not there. Doctors are not God. Doctors cannot endure the pain of seeing unavoidable deaths every single day. The doctors are bent out. Doctors are struggling in their social lives, divorcing, not having time with their kids, because they are dedicated to trying to make sure that every additional life that we can save gets saved. Now, when looking at the NHI, one gets concerned from where we are about how implementable the NHI is going to be. I will start off with looking at, let's start with accreditation of the facilities. When you look at the OHSC report, the OHSC being the one that's going to accredit the facilities, you find that less than 20% of the hospitals actually meet the standards of the OHSC. So it means looking around us, the hospitals are not ready. We've got less than 20% of the very few hospitals that we have being capable of servicing us. So when we now start looking at prioritization, then you then ask yourself, what should we be prioritizing at this point? Should we be prioritizing a funding mechanism, or should we be prioritizing saving lives today? As doctors, we need the healthcare system to work today. We needed it to work yesterday, but yesterday is gone. We still have today. The second thing I would like to highlight as well is, as members of the community, especially the black doctors, you do hear of black tax. I'm sure most of you are familiar with it. So when one speaks of additional tax to fund the NHI, was saying the majority of the black people are already paying black tax. How much more tax can we endure in order to sustain the healthcare system? We speak as doctors because, again, we get concerned about the community. So we've even gone beyond looking at how people are clinically to saying what are the social determinants of health, what happens in our social system that enables the healthcare, our health to improve. Now, when you tax the people that are trying to assist again in solving those social challenges that destroy someone's health, then we ask ourselves, how much is the tax base? How much are the people? How much are the youth that are trying to work themselves out of poverty going to be able to sustain in terms of additional pressure? Because beyond that tax, we can't let Ogogo die of hunger. Without that tax, we can't let our young sisters and brothers to not have clothes, to not go to school. So again, when we think of the NHI, we need to ask ourselves, how are we going to fund it without causing additional burden to the black masses that are trying to get themselves out of poverty? The other thing that I think this one is going to be a more technical one. It's again, when one gets to listen to the NHI, and the presenter said it right, it is a funding mechanism. But when you go through the bill, there's a lot of health systems issues that do not belong in an insurance bill, that actually belong in the National Health Act. So my request, or our request would be, could we remove those health systems issues, and so that we do not confuse, especially the communities when we engage them, because we're talking of two different things, and then approving one. And the one that we're approving, which is the insurance, is the one that we're not talking about. And so you'll find that as we discuss, many people are saying, we want universal health coverage. We as the doctors want universal coverage. We do not want anything less than that. But right now, can we keep the bill at an insurance level so that we can focus on improving our healthcare system? So I think with that, I'd like to say to the community, the doctors care deeply about you. And at any point that you hear us talk, please do not assume, please do not think that we speak from a position of privilege. Our own relatives are out there in the long queues. We cannot pay for all of their medical aid. Thank you so much.
Thank you. Announcement. Thank you. I have an announcement before number 10 speaks. Koloya registration number GHB H80G. Ishifta mo emeng itibile tsela. GHB 880G. Thank you. Number 10.
Thank you, Chair. My name is Jacob Munari, the resident of Sebuke, Ward 35, the chairperson of the ANC. Chair, many of our speakers cover certain things that I want to supposed to engage on this issue of national health insurance. But I just want to get a clarities because we know this issue, national health insurance, it's okay. It's been a long now, since from 2007. There is a resolution of the ANC, knowing that we are clear about the Freedom Charter. The Freedom Charter put it clear that all people must get a free health care. So we are in the step now. We are supporting this national health insurance, now how my chair alluded. My clarity is on issue of workers. This national health insurance are now high no affecter those who are having a medicals. Remember, there are certain people that are not in medical, and there is a scheme. So the scheme and those who are medicals was going to facilitate those two things. So there's a free healthcare scheme and those who are having bonitas, blah, 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 blah. How are we going to manage those two processes during the process of national health insurance? Two, here in Sidibeng, Renali only a one hospital. I don't know how we're going to manage those who are in the process of implementing a national health insurance. I'm working at Spokane Hospital as I'm speaking. The capacity of our hospital, inyane haholo. The staff itself, Spokane Hospital, sisinyane haholo. So I don't know when we're implementing this national health insurance, those who are planning, they are considered the staff or the capacity of staff or the number of the staff in certain facilities are going to manage the process of national health insurance. Other thing, concerning our community, we hear the speaker saying, if ever there's any accident now, accident MP. Botrin 911 if they are going to select owner medical, owner hana medical, then the chopper is going to take those who are having medicals or not. Or the tlonka bana belo winking, bapelo mapelo abona atietina. Hobane normally ke a tseba mona ko hae ho sebetswa jwang. Bana ba nang di medical le ba sebetsang le private. Hunkuwa bona o suwa bana ba kulang haholo. Bana ba kulang haholo ke ena a shwa man. Hunkuwa nna ha fitla ka ga nkanyetsi ke batla metsi. One way trailer one. So they want to cover those things now. We select in the accident or we take those who are having that who needing that care immediately. So in that input, I'm supporting the national health insurance to be implemented. Those meetings said maybe no last we are going to implement this thing of national insurance. Thank you.
Thank you. Number 11.
Nyabonga leadership nabantu bemphakathi. Mina ngayigama nguCebo Zwane. Dietitian is a profession ngithunyelwe department yami eSpokane Hospital. Nombuzo, umbuzo oqala uthi currently kumanje njengoba iNHI ifunding ifuna ukuzanya ukuimplementwa, more than 50% population esiphila kuyo kumanje abanayo imisebenzi. Number 2, most of the population yethu esiphila kuyo kumanje esihlala kuyo phakathi sukuma informal settlements. And uchairperson ukhulumile ngaphambilini wathi kunamanye ama conditions angeke azakhave iNHI. Wathi ngeexample noma mhlawumbe enze ipost ngizamxolela. Wathi uma ushile noma ufuna ulungisa isikhumba esandleni, iNHI angeke ikwazi ukuthi ikhaverele. Manje umbuzo wami uthi njengoba singabantu abantsundu singanamhlaba sihlala kuma informal settlements, sihamba nezikhunga ze climate change. Siyabona imikhukhu iyasha, meaning ukuthi mawukuthi iNHI angeke ikhave lokho, ubani ozokunceda njengoba idura kanje mawuba ushile kulawa ama informal settlements. Umbuzo wami oqala. Owesibili ukuthi why si leadership njenge province singabantu Kuba lukhuni ukuthi sibuze lo mbuzo lo ngoba number 1 asikawenza umsebenzi ukuthi sihlangane na wonke ama association are related to yona national health funding. For an example, ama organization, ama union, nama practitioners because yiba abantu abokuqala bazokhona ukubona wona lawo ma patient. Ukuthi sekudiscussiwe na ukuthi bazokomeliswa kanjani ngemisebenzi abazoyenza ku NHI asikakutholi lokho. That is number 2. So le question engibuza yesibili ibuyela kuleyo yokuqala ukuthi bekuzojabulisa ukuthi sisonke singumphakathi sifike la nabantu bethu baku legislature sixoxisane ngokuthi leyo mali leyo imali enje efunakala izokwazi ukuphuma kanjani rather than sibe nemibuzo eminingi yokuthi ngoba ngeke ngazi ukuthi namhlanje noma kusasa mangeke udokotela uzongicharge malini even inshaya namhlanje ingakwazi lokho. So ngiyacela ukuthi njenge leadership yethu esonke njengoba siyivuma le NHI asiqale niqala sihlanganise wonke ama organization qala basicacisela ukuthi yipi inkinga abazoba nayo noma inkinga abayibonayo isasekhona ku manje sikwazi ukuthi siyilungise mase siyilungisile saqeda na wonke umphakathi sesiyafika emphakathini ngoba yibona abantu abaimportant ukudlula wonke umuntu olapha phambi kwethu. Ngiyabonga question Chairperson.
Number 12. I think one of the questions that he asked was about the a bent person, and I think here it is referring to cosmetic surgery. But when a person is bent, it's not a cosmetic surgery. So I think there must be a difference between a person who is bent, who need to be corrected, who deserves to be corrected, like a person who need a sharp nose. That is cosmetic surgery. Please, let's also clarify that, ne? Because here we are dealing about the conditions that are affecting our people. If you are bent, you will be getting help from those who will be helping you correctly. Can we get number 12?
Dumelang. Lebitso la ka ke Lebohang Mogele from Sidibeng district, from Treatment Action Campaign. Lebohang is a person living openly with HIV and AIDS. Ngishawa mingi mina. Ngishawa uvalo. Because as a country, we are good in putting things on paper. We have good policies as a country, but when it comes to ukuthi izinto zifike phansi kubantu, it becomes a problem. But ke asikho lapho. Taba ke ena, we have a lot of challenges to infrastructure vele. We can't shy away from that. I feel like NHI, although it has been a long time overdue, ukuthi kumele iyasebenza khona manje, but there's still a lot of things that needs to be set down and discussed. And also, NHI ihlanganise nama civil society organizations, because there's nothing for us without us. As community members, we are from different organizations. So if our government is not going to include our civil society organizations, then we are not going to win, because we are the ones that are working on the ground. Sisebenza ngabantu, doing ama facility monitorings. And dintho tse re di tholang mo di facility, healthcare facility, re thola mathata. You see the ceiling yawa, sewage imatha ka mo batho ba emeng ka teng. Yet ho thwe re tlamehile re be safe, re be healthy. How are we going to be safe, re be healthy? Whereas metsi ka hara clinic amatha everywhere. So before re tlo bua ka NHI, let us fix whatever. Even I know department Treatment Action Campaign has been saying the healthcare is collapsing. We ended up saying it has collapsed because of the challenges when we were doing facility monitoring. The other thing now it's a question. I heard in Tatiana presenter the bill the NHI is going to help us or risk stigma and discrimination, and there's going to be professionalism. Are we going to get it? We are working already. The healthcare workers are frustrated from head to toe. Ba frustrated bubona. Haba gaiti bo abuti bao le bo mme bao le bo ntate bao. They need intervention ya government for them hore ba tlo re fa quality access to healthcare services. Qalang ka bona pele le ba lokise le ba kgathalle. I recommend hore maybe government each and every 3 months take care of your people, because at the end of the day what they are going through it a corona. I end up in Nakibitswar when now lebohang was dula it out on kadi ARV tsa hao. It's not everyone as a bua ska lebu about status tsa high. We understand, and we have to encounter taba ya hore ko facility re emarily 5 re tsa pap smear ka mo nna ke betheng ke tswa pap smear. So taba ya infrastructure re kopa government ya enkele kop too. Thank you.
Number 13.
Dumelang bagolo. Lebitso la ka ke Thapelo Mokone. I'm from Merafon City, ko Khutsong. Ke tswa ko Hot 12. Ke bereka as a district coordinator ko TAC, supporting Western District and Sedibeng. Ke kene mo tabeng. We just as the public servant, ke nahana hore re tlamehile re understand hore NHI e tlo re etsetsa eng when coming to the facilities tsa rona tse re di sebedisang. And then ntho e ke batlang ho e tseba ko hore between public health service le private ke eng e tlo etse, ke eng the difference, ke eng if ke nahana hore re tlamehile re itse hore if ke le moduli wa mo Boitumelo and then ke thola accident ke ya ko nthweng ena ko private, amme the government ke NHI ke yone e tlo patalang kampo yang. And then the other thing ke batla ho tseba hore NHI ha e tlo implementiwa. Well, we are having challenges. Yes, but once infrastructure, it's a problem. Yes, it's a problem. Between these two districts, infrastructure is a problem between West Rand and Sedibeng. So, before we can implement NHI, let us try to fix the infrastructure. Because you cannot implement NHI well. The patient at the Bonolako clinic. You can't implement NHI mopleking in Singyal. Mopleking is infection control. You cannot implement NHI. Let us fix our infrastructure before we can implement NHI. And then the other thing, we are having a lot of challenges when we are going to the facilities. We need to but ba re savang kampo ba re fang ditshebeletso tsa bophelo ba na le ke batho le bone ba nna frustrated. Sometimes o ya ko clinicing go sebetsa nurse tse 4 and then batho ba bangata mo teng mo, so that cause go be le long waiting time. That cause delay mo facility. So if our government akashebella hore mo di facility tsa rona ho na le staff se kana kanang, staff se enough now because of really shortages of staff mo di clinic tsa rona. It's a challenge. So the government must look on that happy hore mo facility tlamehile ho be le staff se enough. And then again, as really TAC, we do support NHI. Re shapela monwana re a implementiwe, but NHI tlamehile implementiwe dintho tse re llang ka tsone di lokisitswe. E ka se implementiwe NHI ka se implementiwe well, we are still struggling mo di facilities tsa rona. So ke a leboga bagolo. Thank you.
Thank you. Number 14.
Dumela. Na le bitso la ka ke Mogela go itse Modimo. So ke na le a clarity seeking question. But ke na thabile for medical aid to implement and we all know that as South Africans re tlo benefit re le bangata. And Ra tseba hore kaofela re fortunate hore nka kgona ho afford medical aid. So my clarity seeking question ke hore if medical aid o implementuwa, re tlo suffer ka tax or financial budget ya country. So yeah, ke question ya ka ye. Thank you.
Number 15.
Amanda! Amanda! My name is Lazarus Motloung, Deputy Chairperson, PSA CDB. We as PSA and CDB, we are welcoming the presentation on NHI. However, NHI as a funding and NHI and in versus our infrastructure, medical equipment, medical supplies. What you are presenting today to the public, I hope is not going to end us in a loggerhead with the community as healthcare providers. Because what you are selling now to the community, they are going to come and they are going to want what you are selling here. And when they come to my facility and there is no BP machine that is functional, is something else that you are selling here. When they come to the facility and there is no Panado, they are still going to remind me as the healthcare provider to say, NHI said. That's all that we're trying to raise here to say, we welcome NHI, but we need to deal first with the challenges of procurement, of the facilities and the bola, hanyani. That is one other thing as PSA that we'd like to raise. And the other thing is, are there any policies during this implementation of NHI that are safeguarding the collapse of the other? One, me sitting here, believe you me, as a government employee, and you tell me NHI that the provisions is going to be the same, there is going to be magnitude of people that are canceling their medical aids, believe you me, from here. So what we are looking at the collapse of the other part. And what is it that the NHI has in that in terms of the provision? Secondly, we are looking at NHI once is going to run out of funds. Believe you me. Because there are no policies that are safeguarding the looting and the corruption. That I foresee happening with NHI. For an example, I like the example of the master of ceremonies saying, or the chairperson is saying. She said, cosmetics only for those who are banned, right? How are you going to see? What is it that is going to provide you with the proof that I did this operation with my doctor and you're going to fund it, but I would say I was banned? All I'm saying is, what are the policies that are safeguarding that? The looting and the corruption that is bound to happen in this NHI. And now, the other thing is the working class who are struggling financially due to the medical aid contributions. I think I did speak about it when I started. We have people who are learning very less and who are actually forced by the system to have medical aids. Our system is actually the one that is forcing us to have medical aid. Because there is one thing that I'm going to tell you honestly and right now. Where I am working, providing a service with these limited resources and broken down buildings, I don't want to see myself laying there, myself. So it becomes a problem now to say, you are saying NHS is going to provide this ideal, and the picture is very beautiful. But are we looking into the issues, the real issues before we actually roll out the fund. To say, if ever, whatever that I'm going to receive in Kanyezi or in the private sector, is it going to be the same on this side? Do we have capacitated staff? 1. Do we have enough staff? 2. Do we have enough equipment? 3. Do we have facilities that are compliant? 4. So those are the things before we start rolling out that we need to fix. Because at the end of the day, this NHI is going to pay the private sector. This fund, it is still going to go to the private sector. The thing that we are trying to say, healthcare for all, but the beneficiaries of these funds are still going to be the buildings and the facilities that have complied. And currently, we know the private sector buildings, they do comply. And they are the ones who are going to benefit from this NHI, whether we like it or not. So we need to safeguard from there. Let us fix ourselves first. Let us fix our buildings. Let us capacitate our staff. Let us have more people on the ground to foresee that this NHI, it is visible and it becomes a reality. Thank you.
Thank you. Number 16.
Dumelang, le kae? Ya mona ke Sello Mutsiri Kharudi. Ke member ya South African Council of Churches ya Gauteng Province, an executive member also ya SOSIC nationally, and ke moruti ko United Reformed Church, and ke chaplain ya Diponso people in disability, ke chaplain monu. And then also, I'm a South African. Now, ke batla hore ntho ya pele ke a leboha molao ona e leng hore ke papiso e leng hore tlamehile re endorse. Ke a o ananela ke le motswala wa mona South Africa. Ntho ya pele modulasetulo ka re community ya batho bao e leng hore ha ba itekanela. Hona le mathata e leng a gap e leng teng ya communication space. Mo e leng hore ha ba ya bo di clinicing dipetlele ha ona batho ba e leng hore ba translator ba translator. Meaning we need to re close that gap hore le bona ba tle ba kgone hore ba fumane mesebetsi, because re na le batho ba kgonang ho translate for batho ba e leng hore ba utlwi le ba e leng hore ha ba bone. Me hape hona le challenge hape ditokomaneng tseo re di fumanang tsa medical notes, anything e leng dipetlele le di clinicing le hona dingakeng ha ona dingolwa tsena tso thweng di ngotswe ka braille. Re kopa hore le yona taba ene shebuwe hobaneng re a tseba hore naha ya bo rona mo president o ile a endorsa sign language dikgwedi tse sa tswang ho feta. Me engwe ya cosmetic surgery.
Thank you. Number 17. Askis. You can collect this one. Wakil, take this one. I thought you were handing over. Sorry.
Cosmetic surgery must be considered and also funded. The new scientific improvement. Joloka batho ha ba neng ba robehile ba lemetse, because se rena le dintho thweng ke di robotics mo leng hore dintho tse tlamehile di schedule le tsona. Mme hape potso ke nang le ona ra utlwisisa ke na ananela section number 5 e reng re tlamehile hore fingerprints must be taken and so forth. Rona Afrika Borwa re batho ba ananelang matswantle, empa ha o le a South African o ya country tse kantle, you're being mistreated on the side of healthcare. And countries tse ding ibilane ba o botsa hore how much do you have so that you can qualify for visa on the health sector. Jwanong re batla ho botsa hore nang anang this NHI anang it is preferably the bona fide first of South Africans. Before re ka sheba hobaneng hona le a huge distress in the health sector. Re a tseba re bone malwanlahleng in our Facebook batho ba ne ba lwantsha the MEC wa health Limpopo. Hana emela nnete a re South Africa must be first on the health sector. Re bone situation hape e etsahetseng ko Marshall Town. You ask yourself hore of ko flateng mikhukhu ile teng, where is the health inspectors in that time to check hore batho ba neng ba le mono ba ukene ka hare ho di buildings informally so. And then also re kopa hore re botse this NHI anang itla sheba hape hore ma South Africa tabeng ya di-hero for job seekers. Re a tseba hore dipetlele mona hona le batho ba bangata, specifically di-cleaners o fumana hore ke di-foreign nationals. Empa ho botjwe South Africa tlamehile badudi ba teng ba thole mesebetsi. Empa ho botletse bona re kopa hore South Africa ha re tla mo NHI ha re lokise ntlo ya rona pele before re ka etsa dintho tse ding. Mme ke kopa hore re shebe hore ha re bua ka NHI benefits re dule tabeng ya hore ha re tswela ka ntle re le ma South Africa re kopa hore le yona e re benefit hore ha ebaneng o lemala ka ntle o le moahisane kampane o le motjhaki country e nngwe e ska ba taba hore the foreign country ere you must pay your health services out of your pocket. Ke a leboha.
Thank you very much. Number 17.
Dumelang bagolo. Ka lebitso ke nna Ratanang Makwasello. I come from Badirile, Ward 1, under Rand West Municipality. I hope that all leaders who are there, they know where I come from. But I will explain. I believe that our yesterday's struggle, they still the same as present, Bagolbaka. There's nothing that have changed. Go Bramley, we don't have a clinic to start with. It's a clinic that is located at the MPCC. But today there's this NHI that we must adopt here and say we recommend NHI. A community of 20,000 people as non-clinic. Yesterday we almost lost a sister or pregnant because of your people. Bale berekela, they come go to clinic with their pride. They say 4 o'clock. Also pregnant, those are people who are employed by you. And then the other thing is, this clinic serves predominantly black Africans. One could not believe that elderly people, mothers with newborn babies, and other sick people are greeted by the stench. Surichi tuberile, arena clinic bagolobaka. And then I'm here today, Kudwa and NHI, exciting next year. I'm here begging bagolobaka, let's take care of South Africans before any other policies they come and be implemented. Let's implement this police that is not going to serve our interests as black people. Champion our interests first. Ki kopa fela di park homes le MMC tsa re tshepisitseng tsone di tle go Ward 1 go Brandflay. Or ki bua mo ke le motjha bagolo ba ka se thread mara le tla kra ko N14. Ke a leboga.
Tla ke dumedise bagolo. Ka lebitso ke Godfrey wa Galepono. I'm a field worker at the Parliamentary Constituency Office in Mohali City. Ke batla gore ke endorse the NHI. with exceptions. Go na le ditleliniki tse e leng gore they were long built, 2014. Go Khutsong, there is a clinic that was built in 2014. The clinic is it's an ideal clinic, very beautiful clinic that costs millions. Let us make sure that we open that clinic. Because of like my brother Olewako Treatment Action Campaign who was speaking, he's telling the truth. There is a clinic, ya Mkuku, ko Khutsong, ya Nela, ya Wela. When we do facility monitoring, we are looking at those things. When we do oversight as parliamentary constituency offices, we look into those things. Right now, there is a clinic in the Barking, the ceiling falls down. Ablution facilities, it's so bad. So now when we say we're going to implement NHI, let us look into the facilities. We built these facilities for our people. Let us make sure that we finish those facilities that we built and in time, so that when implementation ya NHI we know like infrastructure is good. Those like good, let us ready to be. There is also another one in Manzeville, in Manzeville. The material that was built, that was bought, is stolen in that facility that was supposed to be built by now so that we can be able also to alleviate the burden. Dr. Yusuf Dadu, we need facilities to the right for NHI to work for our own people. So, but all in all, we say we endorse the NHI. Thank you.
Number 19.
Dumelang.
Ahe.
Ke a leboha. Ke rata ho tshwaela ka tsela e. Ke nna ke di bone wa Mahlas. Ke tsa Ward 6 Bophelong. Motseng o monyane o nyatsayang ma go ntshitseng bahale. Department chairperson le portfolio committee ya hao ke kopa ho tshwaela. Re na le tletlebo jwalo ka setjhaba. Ho na le ntho eo ha re sa e lokise ha ona mo re tlo yang teng. Ya pele re tlamehile ho change the way ne re etsa dintho ka teng. We need change. Re tlohelle re ngole dintho be di sa implementuwe. Ya bobedi ke hore hona le lesoba ke tlo e bitsa basket between community and the portfolios. Department of Health le community hona le lesoba haholo. Why ke tjho jwalo? Hona le need makweisheneng mo re dulang teng. E re ke bua ka clinic ya Bophelong. Clinic ya Bophelong e nyane, e shorta staff, re na le mhlomo le park home e one. Ke kopa ho le jwetsa fela ka Bophelong ho etsalang. Bophelong e sebetsa ka ke Bophelong ba khale, ke di extension tse 18 tsa Bophelong tsa ba ibitsa Movango. Re na le squatter camp. Ho tjho hore re ananela NHI. Mara bothata ke hore a re qalelleng re change. Is a high time ke le rutlwe jwalo ka community hore re hloka eng. NHI ga ananela empa hona le dintho tse tlameleng di lokiswe ene ka pele hore NHI ha e fihla e be etsa ho sna mathata haholo basebetsi ba health ke di MPO ka fa ke di okay batho ba sebeletsang ba thusang ka volunteer ba tholang stipend ba sokola batho ba bulang di organization ba batla ho thusa la lona health ntho e re sokodisang makeisheneng ke health certificate and ha o sena health certificate ha ona mo tla yang teng ke tla ngola tse ding hobane ke na le tse ngata ke kopa departmenteng ya lona le adopte this concept, e leng concept e tla le thusang. Assets-based community development. Assets ABCD. Let us change the way we are used to do things and listen to communities and support them. And community, ha iketsetsa dintho, lona le ba support, di a tsamaya hantle. Ke a leboha hore le thusane le makhanselara a ska na toitoela so. Ke a leboha.
Thank you. Number 20.
Number 8, number 19.
Come in as number 20.
I'm at number 19.
Yes.
You're at.
Yeah.
Oh, thank you very much.
It's okay. I know you are number 19,
Thank-
but I don't know what number did we miss.
Thank
But it's fine. Continue.
Thank you very much, Chair. Thanks for the invitation for us to attend the session. Really appreciate it. Thank you to all the honorable members as well as the audience. Chair, we fully support the fact that the President has signed the Sustainable Development Goals and the obligation that's created on all of us to try and make progress towards universal healthcare coverage is
Sir,
important.
Sir, remember the principle. We agreed in the beginning that we indicate who we are and where we come from or the organization that we represent. Just a reminder, sir.
Yes,
Thank
Chair, I'm
you.
coming to that. Thank you very much. What I was saying is we all support universal healthcare coverage. I'm Dr. Rajesh Patel. I'm the head of health system strengthening at the Board of Healthcare Funders. We are a representative body of medical aids in the country. Chair, we fully support universal healthcare coverage, but we believe that the NHI bill in the current form will really not help us make progress towards universal healthcare coverage. And I'll give you various examples as to the implications of this bill in the current form, and it really needs to be fixed in a consultative way as we move forward. I think I want to talk firstly about how it's going to impair access to healthcare. And the first step for everyone in this audience and yourselves and us is obviously registering as a user of NHI. In order to use the NHI, section 5.5 I want to make reference to. It says you need an ID, but we also need a full unabridged birth certificate. Now that is one of the examples of typing errors and drafting errors in this bill that needs to be fixed. What it probably meant is that adults need IDs and children you need birth certificates for, but the way it's written now, all of us in the audience right now, if we go to register, we must have our full birth certificates and our ID, and I don't think that's correct. The honorable member asked a question earlier about if one of my family members is not registered, can they get access to care? They will not be able to get access to care from an accredited and contracted party or facility. The way it is worded is that if a facility is accredited and contracted, they can only see people who are registered for NHI members or registered with NHI. They cannot see anyone else who's not registered. And that, once again, is a drafting error. And we believe that this is not correct. They probably meant that, yes, you can see NHI registered members, but you can also see those that are not registered in the facility, except for those people NHI will not pay for. That is what is meant. And I think these are the important drafting errors that need to be fixed, Chair. There's additional problems that have taken place there. The whole process of accreditation is very, very complicated, and it really needs to be simplified. What is not mentioned in the bill, any health facility that wants to contract with a state entity has also got to be listed in terms of the Public Finance Management Act with Treasury. So yes, you need to go through the certification, the Office of Health Standard Compliance, get accredited with NHI, get yourself listed on the Treasury website as a service provider, and only then can you be considered to get a contract. This is very complicated, and I think we need to streamline this, especially if we want to improve access to care. There's an important constitutional issue here. The powers of the province are being undermined by something that's in legislation. This legislation, if it goes through, will take away a significant amount of powers that the province actually has at this point in time. there's a recommended amendment to the National Health Act. Various activities that are currently carried out by province are to be taken away. And they are to be taken away and moved to either National Department of Health, NHI, Office of Health Standard Compliance. What that will do, Chair and honorable members, it will create redundancy, staff redundancy in the province. Some of them might go to the National Department of Health, NHI. Some of them might be going to Office of Health Standard Compliance. But there are 9 provinces. How will we accommodate all these people that might become redundant? So definitely, if this bill goes through in the form that it is, with the amendments in the National Health Act, there will have to be retrenchments. Where will the province get that additional money to retain the staff? And I think that's important. We have in the National Health Act the creation of district health authorities. There's about 52 that need to be created in the country. We are almost 2 decades down the line since National Health Act was published. We don't really have fully functional district health authority. But now we want to create a couple of hundred contracting units of primary care and health management oversight offices, etc., etc. And I think what we are creating is a bloated middle management structure that is totally unnecessary. How can we call it a single payer if we're going to take money, go to contracting unit of primary care, and that unit will then pay the service providers? That is not single payer, that is multi-payer system. And if you want to do multi-payer system, open it up for other purposes as well. I think what is important is, if there's a law in the country, you don't need to create another law stating the same function. What the amendments that are created in the medical scheme amendment in part of that bill is totally unnecessary. Those provisions are made in section 33 of the NHI bill. But what they do also state is that medical schemes will not be able to offer any maternity cover at all. So if the president does sign off this bill as is, all maternity benefits from medical schemes will stop with immediate effect. What that will mean, anyone who's on medical scheme who wants to have maternity care in private sector will have to pay out of their pockets themselves. Okay? Or if they want to get maternity cover, they will have to go to the public sector. I don't think that the public sector can cope with this additional 8.5 million lives for that maternity service to go there. 2 weeks ago, one of the doctors who works in one of the outlying community hospitals has said that in his ward, out of the 25 beds, 2 are occupied by South Africans, the rest are occupied by foreigners. Where will all this additional burden go to in the public sector? So there are problems with this bill, the content of the bill. We need to take out that entire medical scheme amendment component out of it. In 2018, at Parliament, there was another medical scheme amendment bill that was proposed. If you want to change the Medical Schemes Act, do all of it together, not in drips and drabs. Let's make sure we do things properly, and let's fix things properly. A lot was said about the many priorities in healthcare. NHI, yes, it's an important thing of finance reform, but in the priorities of all the other services, it's lower down the order. Comment was made about let's fix infrastructure. You can't have a facility and not have toilets there for the people that attend. People stand there for 6-10 hours before they get attended to. That is unacceptable. We have, as we're standing and sitting right now, we have many unemployed doctors, unemployed nurses, unemployed pharmacists. Let's allocate some work for them. Instead of creating a bloated middle structure like the SCUPS and district health management systems, take the money that you want to allocate for that and let's employ all these people to deliver care to the public, Chair. One of the big problems that there is right now that also needs to be addressed, and we're not doing enough about it, and the regulators out there are also not doing enough, is the quality of care delivery to the public. We need to help beef up the systems. Although people like myself work in the private sector, we're not having a castle of our own. We have offered our services to the public sector, to the provinces, to extend some of the free time that we have to assist them in whatever they need to do to help even improve the quality of care, and perhaps some management systems that need to be improved as well. There are many, many, many regulatory bodies that are grossly underperforming. We need, in the meantime, to get those regulatory bodies fixed. Comment was made by the doctors, etc., about the problems they experience. The HPCSA is out there, but it's dysfunctional. They're not doing the essential things that they should be doing. Right now in the news, it's about the foreign doctors. They can't even get exams taken. If we can't do some simple things like that, how are we going to do the rest of the big things we need to do? Chair, the way NHI is structured at this point in time, it says that the Benefits Advisory Committee, the Ministerial Advisory Committee, will determine what benefits are to be offered in the NHI. What it means is that the board does not have control of this. It's a Ministerial Advisory Committee. The board will not determine how much money it needs to provide for the benefits. Money that is needed for those benefits will be determined by Treasury. That same structure exists in Road Accident Fund. Do we have a functional road accident fund at this point in time? Think about that. If you want an accountable NHI, empower the board. Let the board, that medical benefits committee of the board, become a subcommittee of the board, not a ministerial advisory committee. Let the board then determine how much money it needs to provide services, not to leave it up to Treasury to determine how much money to be allocated. Otherwise, we're going to have a similar problem like road accident fund, because the governance structures as it is right now, the board is not sufficiently empowered. Most of the power actually sits with the minister. And while the current minister, there might be trust in him, who's to say that ministers down the line may not be different? I think what is important, there are so many flaws in this NHI bill. It's important to create a kind of a consultatory process with all stakeholders to come in and actually contribute as to the exact problems and exactly how we fix it. BHF has made its submission already to the NCOP. We will today make the submissions to the province as well. And we will, in our submissions, we've listed the problems. We've also listed recommended solutions for those things. Chair, one of the important things before we create an NHI, let's convince the public that we've addressed corruption before we introduce a new entity. If we don't have trust in government, how can we trust them to run an NHI? And I think that perception needs to be addressed immediately, Chair. I want to end up in saying the first statement again that I had earlier. NHI, as proposed right now, will not help us progress towards universal healthcare coverage. Thank you very much, Chair.
Thank you. Number 21.
Dumelang, Obu Amfake Khomotso, Mudise from Heidelberg Hospital. Thank you, Chairperson, and the leaders from different portfolios. We welcome the presentation, but from where I'm sitting, I cannot really say if I'm for or against the NHI, because not enough information has been shared with us, especially healthcare workers. So all the challenges that has been addressed already by the speakers that spoke here, can they at least be given attention and be addressed before NHI can be implemented? And then secondly, I would like to just ask, and the doctor did say, Bakhaitsu, we are not talking from the point of privilege, no. Renale, lidi family, lorona, those that we know they can benefit from NHI. However, we are stretched as well, lorona babereki. So my question to National is, implementation of NHI, will it not put a burden on our already burdened tax as taxpayers? Because tax is really killing us. Sometimes we feel like we are just going to work just so that we can pay tax and not be able to maintain ourselves. We know, yes, the people that are coming from the under, what do they call it, the socio-economic status, We know they'll definitely get to benefit, and hence I'm saying we are not against it. No, we are for it, as long as it's not going to put pressure on us. So my question really is, will it increase our tax? Nah. If it's not, go ahead. Secondly, there's something that we heard that employees that are earning a certain salary bracket will have to contribute irrespective of whether they have medical aid or not. Is it true? Because if it is, honestly, it will be unfair of us to be paying double. So there is something that we'd really like to get clarity on it. But like I said, if it's not going to put pressure on us, then go ahead. Thank you.
Thank you. Number last, the very last speaker on my left-hand side. Come in, sir.
Thank you, Chairperson. Sanbonani, igama uKhaya Skosana. I am from the Board of Healthcare Funders. Thank you very much for the opportunity to express our view. As BHF, we do support the universal health coverage, but not the bill in its current form. And I'll elaborate on why. My previous speaker, Askhumutso, has raised concern about this bill raising more taxes. Khumutso, I'm sorry to say to you, I'm an accountant by profession, and I've looked at the numbers. I can tell you there will be tax increases. At this point, the bill is not clear in terms of which taxes that's going to be. It talks about payroll taxes, so it could be that something similar to a UIF is going to be introduced, so you're going to pay more tax, or income tax, that's going to be more, or even VAT itself. So yes, the government is promising us a very good system, which is universal health coverage, NHI, but it's not going to come cheap. They tell you you're going to go in and not pay at the point of service, which is true. That is how NHI systems work. But it's going to cost you in other ways. You guys remember the e-tolls. They promised you these wonderful roads that were going to come, and we did get the roads, but in the end we had to pay. And that is why we took to the streets, because the aspect of payment that we are going to pay for this system was not elaborated in us. Anyway, what I wanted to say is that there are two preconditions to access to healthcare. Number one is funding. NHI is a very good thing because it addresses funding. We require money to pay for health services, and that's what NHI is going to do. So we are grateful for government for thinking about it, to say, yes, we need that. But that's just one aspect. That's one side of the story. That's one side of the equation. The other side, which is most important, and most speakers, I'm glad, have spoken about it, that is the availability of the healthcare infrastructure to provide the healthcare services. So even if tomorrow you could have a working NHI fund where you have a big pot of money that is available to pay for healthcare services, unfortunately, the majority of our people are not going to be able to access that healthcare because we do not have a working healthcare infrastructure. Our infrastructure has collapsed. So the thought that you are going to get healthcare service for free where you're going to walk in and be treated is a fallacy. We are being sold a fallacy. For us to have access to healthcare, we require healthcare infrastructure. The private healthcare facilities are not enough. We need to fix our public healthcare facilities. The Minister of Health was quoted as saying that we require at least 200 billion rands to fix our public healthcare infrastructure. I hear the government is pushing for NHI, but like I said, that's just the one side of the story. I don't hear anything about how do we plan to resolve the unavailability, the shortage of public healthcare facilities. How are we going to get that 200 billion to fix the public healthcare facilities? How are we going to ensure that even when we do get the money is going to be directed to fixing the public healthcare facilities, is not going to end up being looted like most other funds that we've seen being looted. So the NHI is a very good thing. We do need it. We do need access to healthcare as citizens of South Africa. But let us not be misled. Let us ask, we want to know what is the plan to fix the public healthcare infrastructure. And by public healthcare infrastructure, I mean the actual buildings themselves, the clinics, the private healthcare facilities, the public healthcare facilities, the private hospitals, the public hospitals. How are they going to fix those? Within those facilities, I mean the resources, the equipment, the medicines. Most importantly, the healthcare personnel. We have doctors with high qualifications who are marching to be employed by our own government. So it's not necessarily a shortage of doctors or any healthcare personnel. It is the shortage of the budgets to hire them. So we can't have doctors that are unemployed and also have hospitals that are lacking in human resources like doctors and nurses. So the infrastructure is referring to that aspect. We need that to be fixed. Until and unless the public healthcare facilities are fixed, NHI will remain a fallacy. So we need the government to tell us what their plan is around that. And to summarize it, in simple terms, the government is promising us a Ferrari, yet they are struggling to provide us with even a simple bicycle. So until they can be able to provide us with a working solution, let us hold them accountable. Whilst they're telling us about the NHI, which is good, let us also ask about what they are doing to fix the public healthcare infrastructure. Thank you.
Dumelang hape in the afternoon. We are done this side. And the issue of infrastructure has been raised several times. Can I request that this side, you do not raise the issue of infrastructure going forward? Because if we raise similar, all the time we are raising infrastructure, it is not assisting because the responders here, they have heard you. So please, infrastructure, we heard you, Lerena as committee here, we are writing notes. Many community members this side, balaka infrastructure. So, kamo citing here, let's not repeat infrastructure. Secondly, if community raises issues and leave this meeting is unfair. Because there are those who raised issues this side, they are gone. When the responses come, they are not here. Why are you raising issues and you don't want to listen to the responses from the presenters? It is not correct. You must be part of the meeting until we are done. Now, there is the issue of 16% that is beneficiary in terms of tax. There are those who are paying tax, but they benefit nothing in terms of health. Can we stop the noise and can the meeting that is addressed on my right, can that meeting stop? Hello? Can you go outside and address that meeting? Because now there is a noise coming from that meeting. If people want to sit down, there are chairs here that are empty. There are also chairs here in front. Because they are Tonya and stage sela se Tonya. Itali dule mo ditulo di empty dina runa batho tsenang ka mohare and sit. Dula mo ditulong as a belief bana beso. So that the risk ba le noise e affecta ka mo re nyoko tloha mo tshaba se boletse ditulo ke tse tsenang le ska tshaba o tsena. Oh, mara okay. Ke lena ba le tlo contributang. Mara are di maleng, and can I ask ma'am who is having a walking stick here now? She can sit down. She can also talk while seated. Ask I men like a mauto. Number one, kamu. Akere bosawe bulela urukuwe na mang representa ing, and then we continue ka input ya haone.
Okay,
thank you.
Dumelang. Lebitso la ka ke Tumeleng ke resident ya Bophelong. I'm not a member of any organization, ma'am. potso ya ka kore, na I'm a concerned youth. Ha re sebetse batho ba baholo, ha re na span. Re a so re ha ra ya sekolong kapa ha re batle ho ya sekolong. Kore mesebetsi ha eyo. How is this going to address the issue of unemployment amongst Rona youth haholo? That's my question. How is this going to help us get jobs? How is this going to contribute in job creation? That's my question, ma'am.
Thank you. Number 2.
Dumelang, lebitso la ka ke Maria Mogele from Kokosi, Ward 26. Potso ya ka ke hore, if it happens hore NHI implementiwe ne, re tlo tseba jwang hore ra qualify for yona, and ke di documents tse feng tse ile hore di tlo hlokahala hore re kgone ho apply for bill ena. Thank you.
Number 3.
Thokozani. Lesedi.
Thokoza Gogo.
Ya bua mona ke Chipiwa Gift Netsanda from Westrand Mogale City. Ke secretary ya the African Traditional Medicine in the Western District in Mogale City. And then ke be chairperson ya the THP's Mogale City under Civil Society Forum. My concerns today, it's based on the link from the NHI together with the traditional health practitioner sector. My questions is, as you had mentioned on the presentation, that there will be amendments, and I've noted that the Traditional Health Practitioners Act is also mentioned there. When will the process unfold? And with the NHI fund, how will the traditional health practitioners be included as healthcare service providers? That's 2. Another thing, next question is on the cost that, as it was mentioned at the presentation, that people will be expected to make some kind of contribution towards the fund. How will the cost be determined, and will it be affordable to a layman that is not employed? Also thinking about the orphans and pensioners. I also have a concern that today, as we are here as Sidibeng and Westrand, the most people that I'm seeing here, it's black people. Where are the white community, the Indian community, unless this session is meant for us as blacks? So it is a concern that I believe this NHI bill affects all of us. And my last one is on the services that the NHI will be covering. I think it needs to be clear to the whole constituency of South Africa. What is it that you will be covering, and what is it that you are not going to cover in the fund? Thank you.
Thokoza Gogo, number 4.
Thokozani.
Thokoza
Tsamagwini.
Gogo.
Lo thethayo uGogo Ntombi from Westrand Mogale City, Deputy Chairperson of the CSF in Mogale City under HIV and AIDS. I-concern yam ndifuna ukwazi ngezinyanga, because thina as izinyanga we are forcing ourselves in many times to be recognized into the health system, and we play a vital role kakhulu, but xa kufika kuthi we need ukuthi sizifake, and kusithi there's no referral to us, and there are no ways apho singathi sifikelele khona kufikelele ukuthi sikhona ukusebenzisana ne-health. There are programs that are done by the health. Basibize, basinika ukutya as the health practitioners, and then that's it. Ayikho into abayithathayo kuthi. The only thing that they take from us is half of the medicine that ezityiwayo namhlanje imishwanguzo, they come from phansi, ziyagujwa sithi. Siyakwazi ukuthi sizigubhe zisebenze, but when it comes ukuthi sibe ne-recognition, asirecognizwa as izinyanga. You understand? So my question is, Tina, as izinyanga kule NHI, how are we going to benefit? Because we have been used for a very long time. There's a system that is implemented right now, here ATM, as Nyang, that we are working with the Department of Health. We're not working with the Department of Health. The Department of Health is using our knowledge so that Tina, sizobanikeza ulwazi lwethu, boda bahlale ezitafileni bakwazi ubethi laptop bayenze whatever bayenzayo, and then thina sibuyele ezintumbeni zethu. Half of the people that are here in the community, they come to us because banezingxaki. Understand? Esikwazi ukubanceda. People who are, hence I'm saying I am a deputy chairperson of the CFSF, HIV and AIDS. What does that mean? It means ukuthi ndiyasebenzisana nomuntu omguli xa egula positive. I can say to you, ndicela uhambe eclinic uyotesta ubone ukuthi xa ubuye ubuye ne-results sikwazi ubona ukuthi xa ndikunika nami imbiza apha, and then iclinic nayo ithini uthatha ama-ARVs. But if i-health facilities, they are robbing us. Thina umsebenzi wethu siyawenza, but there is no referral to us. Umuntu xa ke mbana ukuthi ntoni, abanye bethu abantu ba-diagnosed as bipolar. They diagnosed by bipolar, kodwa umuntu ephethe idlozi. Nobody is referring that to us. So sicela ukuthi abantu bethu ba-referwe, siyacela ukuthi nathi sisetshenziswe ngendlela e-right, siyacela ukungayuzwa. Thokozani.
Number 5.
Sanbonano, my name is Fikile Dikolomela Lengene, a healthcare professional and an activist. When one looks at the NHI bill, one gets the sense of, if this is how socialism is going to be implemented, woe unto the South Africans. Equity, equality, reality of the universal health coverage is non-existent in this current NHI bill that we came here to support or not support. Chapter 2, access to healthcare. Section 4:1. The bill is talking at a very high level on how it's giving an explanation. It's actually making a copy and paste of the Constitution when it talks to access of the healthcare, especially when we are looking at what is basic healthcare when we are talking private and the public sector. Currently, we need to relook or even put an amendment on the Constitution when we are saying that we looking at the NHI in terms of even controlling our borders, which is not going to be so if we shall be offering the basic health care. 4.3, the NHI must provide the equality, comprehensive health care in the use of medicine and even of those of traditional healthcare leaders. Registration of users. Section 5.1. The explanation contained in this bill is very loose on how it is identifying who will be the users or in the NHI. Service providers. Section 5.4. The service providers should be told by NHI that you have the authorization. They must not be given the responsibility to consent or deny, as that will be denying our citizens the right to their health care. The rights of the users. Section 6.6. We go back again, we are looking at the equal quality comprehensive healthcare that will not warrant any HI user to purchase additional care. And I think this is where we are saying as the right of the users, especially the section 6.0. Because what is equality if you are still keeping medical aids? The poor will still be poor in receiving, and the elites who are not here today, the whites who are having medical aids, will still have the power to choose if I want that medical aid or not, or they want the service. And our people will still be begging, like they are doing in such platforms, for them to be heard and have the healthcare that they need. Healthcare services coverage, section 7(2). D, Roman figure 1, the emergency medical health services. First, the primary health care that will be given, we do know that it is PHC-led. That is the first primary level for a poor person, is a clinic. How do we get an oncology patient in the same way with those that have got medical aid in terms of primary services when they present themselves at the facility? Section 7(2)(f), number 3. How do you make semi-autonomous in deciding financial management of a service provider? Section 7(3). If the NHI is to work, destroy the borders. A medical aid has never told a patient that they can't go to a dermatologist in setting. That can be the case. And the NHI must allow patients to access healthcare anywhere in the country without having restrictions because they are poor and black. Cost coverage. Section 8, Roman figure 2. This one is taking us back to the comprehensive coverage. We still reiterate that the NHI must not only offer basic health care, but it must also offer the comprehensive quality care that comes from primary to second and tertiary. It must leave limited room for private purchased health care by those who've got money, still continuing to access even the cosmetics. Yet we do know that we've got women who don't have breasts today due to cancer. We've got children who get banned. They cannot afford those tomology and osteologies as citizens because they don't have money, or the services that they find themselves in. There isn't even those specialists to do those. They are all cropped up for private sector. Chapter 3, the money. Let's talk the money with our government. Establishment of this fund. You are saying in section 9 that the system we are currently under, we need stricter regulations, and I don't think there's any of us who needs to be convinced when we talk comrades, this government and money. The administration of the fund to avoid profit gains. Currently, the system is not working for us, and we cannot have a fund that will also be abused, like the PFMA right now is being abused. Functions of the fund. There are too many loopholes when it comes to this point. Let's look at section 10(1). This fund is going to operate under Schedule 3A of the PFMA. Ebana. Harula Electric, ESCOM is working under that. Transport, they are all working under that. Under the very Schedule 3A of the PMA, all our state entities are currently functioning under that, and we do know the corruption and the looting. Now, transport. Now we will kill them. Function 10, number 10, internal audit and risk management. That one we know it doesn't help with the kind of government that we have today. That system alone is not enough. We currently have those systems happening and money is still being looted. Till today, nobody has even taken account for those looting that are happening. We do have in section 10(3), the bill is citing that there will be health policies and standards. Even in national can come up with a policy of a decision-making body. The provinces change when they feel they are not implementable. There is no reinforcement. Currently, yes, we do have the Office of the Health Standards, but they operate within the existing benefits of the advisory committee. And truly, it cannot be the OHSC again. Now, section 10, for everyone in the bill, report to this minister. The bill is giving too much power to one person. Who is the minister? Who is the goalie, the player, the referee? A very similar situation that is happening currently under the Minister of Enterprise. And we can't do anything. We want to go replicate that and replicate it in the healthcare system. We are dealing with lives, guys, not electric. Ten-4, the NHI bill is compromised and our healthcare system will collapse. The powers that are bestowed, you see, apologies. Now, powers of the fund. Let's talk the powers of the fund. Chelet. Who will be having the fund? In terms of section 11 of the very bill, in terms of suing and defending itself in court, the fund might find itself in a lot of legal battles based on what they authorize and reject. People will take them to the Constitutional Court and get a lot of money, as it was in the case of Life Esidimeni. So we do have precedences. Chapter 4, Board of the Fund. Now, with the establishment under this section 12 of the board, it raises a lot of concerns. With our history of state-owned, like I'm still repeating, we are still repeating the same mistakes, but we want different results. Honorable Einstein. Constitution and composition of the board. Section 13.4. How are we going to ensure that what the interview panel and the board recommends and decides is ultimately becoming the final decision? We have seen how private enterprise minister, Mr. Pravin Gordhan, has overruled the boards of SAA, the boards of ESCOM, up to the collapse of the state-owned entities. And we are taking the very same model.
Can you respect the chair? Can you respect the chair?
I cannot
Can you respect the chair?
Thank you, Chair.
Yeah.
Apologies.
Can
Not
I
on my
ask
ears.
you can't start from A to Z with this bill, because here we need everyone to get a chance. You started from the beginning and you are going all the way. In the public participation, we need everybody to speak. In the public participation, everybody must talk. You can write your points and bring them to here. Write your points. There is the email. Put your inputs to the email. Everybody must speak in the public participation. The public participation is for everybody. Number six. Number 6 is your turn.
Khotsong. Khotsong, dumelang, apsheni, molweni, sanibonani.
Number 6.
Sanibonani.
Number 6. Ulela, my sister. Continue, my sister.
Okay, thank you very much. Dumelang, khotsong. Libitso la ka ke nna Paulina Masitjhaba Mokoena.
Can we give her a chance? Hello? Let's give her a chance so that we gave her more than 15 minutes. That is not how it works. Can you continue, my sister? Can you keep quiet and listen to the next person? I was very generous to her, but she cannot speak for 30 minutes alone. Then I must give everybody 30 minutes. When are we going to get other inputs? Proceed, my sister.
Dumela, khotsong. Libitso la ka ke nna Paulina Masitjhaba Mokoena. Ke eme mona ho tlo botsa dipotso. Potso ya ka ya pele, ke tlo botsa gore neneng NHR ka bill e ya yona, a e tlo implementa ma South African or ma foreigners? Because ke utlwile ntate a bua ka taba ya ma foreigners, gore ma foreigners ko dipetlele le ona a tlo thusa, a tlo kena dipetlele. Yes, re a wa bona a teng ma foreigners, but ma foreigners re bona gore neneng ana le access ho feta rona ma South Africa. Ana le access e ngata e fetang rona ma South Africa, ene ba re jwetsa re bona ba beleha 2 years ngwana hana le 2 years o tlamele a bele na ha a ya clinicing o tlo access o tlo etswa jwalo ka o tlo etsetswa ntho engwe le engwe jwalo ka nna. Ke potso ya ka ke batlang e kopang o e botsa eng. Potso ya ka ya bobedi, hona jwale ska as I'm speaking now ke na le problem ya tseba, ke utlwi ko tsebeng, a ke utlwi hantle tsebeng. So ke sa utlwi tsebeng ke le ka hlekefetswa ke ne ke hlekefetswa lenyalong kwana. So ke batla ho tseba gore neneng e tlo implementa the poor e tlo le the rich na, or the rich are going to get more ho feta rona the poor, or those who are working ba sebetsang ke bona ba tlo enang ho feta rona na? Because re a safarishe as nna ke tsofetse ke lemka ka nako ke badile ka nako ya matric ka Sesotho. I didn't get a work. Ke sa thola mosebetsi, I am a volunteer. Ke volunteer ya a caregiver. As ke le caregiver ho bohloko ntse tse kopanang le tsona mola di bohloko. Ke a volunteer, a kena income e enough for le nna ke tswedise bana ba ka pele hore bana ba sekolong. Matsoa ka a bohloko ke kopa ho botsa gore neneng e tlo implementa re be le equipment mo di clinicing na, equipment mo di petlele na. Dipetlele ho bua le di clinicing ho bua ka health, but who unhealthy re a kula. As re le di caregiver le rona re thusa batho ba kulang, le mo re ba lateng teng ka matlung ka mane re tlameha gore rona re sa kgoleng re ntshe ditšhelete tsa rona gore neneng ba palame di-taxi ba ye ko di clinicing. Ke kopa ho understandiwa hona mo, please. Ke tsona di-questions tsa ka, se ke lebetse tse ding ne di le ngata jwalo nka lebaka la hobaneng nako ha e sa le yo nna ke lapile lo lapa hona no.
Number 7.
Qina mhlali qina. Qina mhlali qina. Mandla. Siyabonga sihlalo ngaphambili. Sihlalo we are here ukuthi si endorse this bill because it is long overdue. And sihlalo remember, siya endorse today. Tomorrow if I save ile bill, isave abongco kankulu, we are going to scrap it. Sibe senza ngeitholi. Igama lami ngungusibusiswa kaKhumalo. Ngisuka eRand West City Municipality. I'm from the organization called Rand West Stakeholders Forum. So ama speakers before me now, they've covered me. So I'm just here to say Nati in our organization we endorse the bill. But if a bill is ukuseva the poor of the poorest, us as the community we've got a power gain to scrap the bill off. Thank you.
Thank you. Number 8.
Molweni nonke icabinet ngaphambili nabantu abahlala bangezansi nomphakathi wonke oseholweni. Lo uthethayo nguNontobeko Khetshana, ugogo uMamiya, ndibuya eCarltonville kuWard 13. Ukuma kwami apha ndimele nokubana ndizoxhasa lo NHI xa ngaba eza kunceda abantu abangasebenziyo nabantu abanebusiness. Uba bangancedakala nabo bakwazi ukuxhamla kule mpilo lesifunayo, ngoba abantu abaninzi ngakumbi thina abantu abahlala ezimine olathuli lwemane zivalwe luza apha kuthi lonke malungana ne-TB. I-TB ke yiyo eqala ifike before kube khona lo HIV, and azosinceda kakhulu uportfolio lo wamalungelo empilo ngakumbi phaa kulaa Blayburg sihlala kuyo. Ikliniki yethu ayinagqirha. Ugqirha uthunyelwa ezibhedlela uza kanye ngeveki okanye kuthiwa akazubakho. Ndithetha ngam mnamntu endinguye endithi xa ndifikile phaa kufama ndiyobona ugqirha ndinengxaki ne-treatment endiyityayo le ye-HIV. xa ufika phaa kulaa gqirha lo gqirha uzothi andazi into ithi ndifowunele omnye ugqirha kanti uziselwe ntoni apha kule kliniki xa ezothi yena akazi into ngamapilisi e-HIV usawukufowunela omnye ugqirha. Yingxaki esinayo ke leyo kulaa kliniki. Bendicela ukuthi njengenekhabhinethi yakwa-health izame ukuxokisisa nijongisise laa ndawo esihlala kuyo ngoba nasifana nabantu abahlala ehlathini asihoyekanga sisibhedlela sethu esithumela ugqirha. Lo gqirha lo xa efikile uzofika ahlale i-2 hours athi ufumene ifowuni yahamba. Enkosi mama ndiyambulela no-NHI makenze asincede. Thank you.
Number 9, Aribulelenka NHI. If lena lady problems to do with other issues, you can come to me, I'll show you who to talk to. Today, Rinyaka ore lena Aribulelenka NHI representile mo today. Number 9. She can, mama, you hlala phansi ukhulume uhleli ungasukumi. Oh unyaka rini.
Dumelang batswadi. Ona a buang mona ke Mamudiani Salamina Bowman. A dulang Ward 35. A ka tlasa lephela sa nkgo la baahi. Batswadi ha ke tsebe taba tsa ka di ngata mara ke tla bua se pedi fela ba ke a utlwa mme gore nako ile. Taba ya ka ya pele. Bili ena e tlisitsweng ho rona. Ha ke tsebe ka pontona mme o re etsa workshop kapa o re tlo e adopta na ha ke utlwisise. Hoba ke nahana re ka ba re tseditse workshop pele ga utlwisisa gona ho bua ka eng. Jwale ka jeno to re adopta ke mona here a dumela re tswele pele. Empa ke batla ho tseba gona le komiti a ntate Ramaphosa ba mmuso le bona ba ka hara yona skepe se se re tlo se palama. Gona batho ba hlokang. Hoba ka re etsetsa gona ba hloki le batho ba parlamenteng ba kgolang entse ba bainda ntho go ba tlo fumana mahala. Ke number 1. Number 2, ho bua ka taba ya bophelo bo botle. Hore yana ke bophelo bo botle. Batswadi re dula ka ga di sorisi nna ha o ka ya ha rona mane ke tsamaya ka ditsetsa kwane ke beile ditene ke tsamaya ka hara sorisi bophelong bo botle. Ha re na metsi, ha re na mollo bophelong bo botle. Jwale ha ke tsebe gore na bili ena o thong re adopt re tla dumela ba ntho engwe le engwe ha re e botswe re a e jwetswa ke a le.
Number 10.
Dumelang batswadi. Ke rata ho leboha Department of Legislature ya Gauteng. MEC ko hlomphile mme wa ka le baletedi ba hao. Nna a bua mona na ke Lebohang Providence Moloi, ke resident ka mane ka Sharpeville. Ke director ya Bambanani Trisano Youth Development Center. Batswadi nna le nkemisitseng ka mona na ho bua nnete fela ha ke na tletlebo because ke bone hore Gauteng ya leka ya re sebeletsa batswadi. So ntho e ke tlo kopang ho lona moifo wa MEC ke hore tswetswe batswadi hle. Ne re kopa le re thusa ha o ya ka West Rand o ya East Rand City of Johannesburg and Tshwane. There is a program e bitswang She Conquers. She Conquers e dila ka women health ene ya bana ba banyenyane. So nka thaba haholo ha department e ka re thusa re implement ka kwano ka haru ho Sedibeng district.
Lebohang.
Ya mme wa ka.
You must come to us, not in this platform. Itlamo hore and then utlori.
Thank you so much, Mewak. Thank you, Mewak.
Itlamo tafleng ne? Yeah. Number 10, 11.
Ke a leboha batswadi. Ke dumedise beng ba motshware ba mosebetsi le setjhaba se teng kwano. Ke tla ba mokgutshwane haholo ka hore taba tse ngata se di bue. Nna potso ya ka ke ena. E sa le taba ena ya NHI e qala. Ho bua ka ho fana ha ditshebeletso health services ho setjhaba ka kakaretso. Mme ka mokgwa ke utlwang ha e beuwa kapa e rekiswa ho the tla ba mahala batho ha ke keng ba lefa. Jwale potso e ke ipotsang yona ke hore na tjhelete eo ya ho tsamaisa ditshebeletso tseo e tla tswa kae? Na e tla tswa budgeteng ya Department of Health, mme pele e fihla moo sesosa sa yona kapa mothopo mo tjhelete e tla fumaneha teng ke hokae? Hore tle re ka tsatsi le le mohlomong ha ditshebeletso di sa di fihlele batho ho thwe tjhelete ha eyo, tle re tsebe hore na e fedile kae? E nngwe taba ke ena, e sa le qala taba ena ke utlwa ho ntso ho etswa comparison ka ditshebeletso tsa mahala le tsa di medical aid. Jwale ntho e ntshwenyang haholo ke hore ke utlwa batho ba utlwisa eka motho ha o na le medical aid ke mahala, ha o lefe ha o ya doctor. Ene ho ya ka tsebo ya ka o le setho sa medical aid o a patala hore o be setho medical aid moo. Ha hona hore tla wa medical aid ka ntle le ha o le lehlohonolo ho na le moo mohlomong mo sebetsang teng ba re tla o fa medical aid wa mahala. Mara ka tsebo ya ka o tshwanetse le wena o research. Nka thabela fela haeba taba ena ya tjhelete ya NHI e ka hlalosa hantle hore nna tje ka motho fela ke kgone ho utlwisisa hore tjhelete ya ho lefa ditshebeletso tsena kaofela mohla taba ena e se sebetsa e tla betswa kae? Ke a leboha.
Before pele o tsamaya a wa bolela lebitso le hore o nna ko kae so that re tlo fa information.
O ntshwarele mme, nna ke Mosotho, ke Maduna, ke Kubevu, ke setloholo sa Mahlubi, ke moahi hona mona Sebokeng, hona mona zone 14.
Okay. Ntate Magoro a ka tlhalosa mo ka NHI hore o e utlwisise. That is you are number 14, so it's not for you now. I don't know hore ke mang wa tseneletseng mola na se a ke sa mo count, because you are number 14 and the next door is number 15 and is the last person. Where is number 13 and 14? I mean, where is number 12 and 13? I was giving numbers. The last person is number 15 and the number 15 is number 2. You are not number 14.
No, she's number
Sisters, you are not number 14.
Number 14, I'm 15.
You are number 14 and number 15. So number 12, if I'm number 12, u fele number 13. Yeah, keep on come on. We're now number 12 and he's number 13, then number 14 and 15.
Number 16. I can't edit 2 acres. So you know
number 12.
Lebitso la ka ke Mahlodi Maqutu. Ke sebeletsa ko Orange Farm. I'm a caregiver. Then ko mmereko wa rona re tlhakana dilo tse botlhoko tse utlusa botlhoko, especially mo bathong ba bagolo. Batho ba holo ba need care. So NHI ha e kenella, so I'm so proud because batho ba holo they need care bathong ba modimo. Bana ba bona ba ba tlogella fela. Rona as really caregiver re mo for bona because ba bang ba need care very very serious. Batho ba bagolo ha bana dijo mo ntlong, but they get grant. Bana ba bona banka grant ba ba sie ba tsamaya ba ba sie ba le jalo ba sena dijo. Rona ha re tla ka usane re tlo ba check. Magogo hana dijo, hana next, and wa kula. O need a medication. Wa tsaba lo mlatela medication. Medication o aka se unwe before aja. So rona re le caregiver and a re gole, re ntsha ditšhelete tsa rona. Re ba rekele dijo. Re ntsha ditšhelete tsa rona, re ba ise ko ditleliniking. So ke kopa gore le government e zame go kenella mo dilong tse ka reng tseo, because e botlhoko, Chairperson, I'm sorry. A se ke tswa ko tseleng.
Sisters, awubuleli ka NHI. Come and see us, we will help you ka social development.
Okay,
Yeah.
thank you.
So ifa number 13, wena
Okay,
itla mo tafoleng.
thank you.
Dumelang, nna ke tlhagela ke le Emmanuel Chubisi ko Carltonville, Ward 13. Problem ya ka A1 ke gore di minister ha di tla di implementa ntho e tla e tle go benefita rona kaofela. Suddenly o makale go te minister mamang o tswile ka tšhelete gore o suspendile. A re jikele ko morago COVID-19 ha e tla. I still remember go tlile di Chinese di re ruta gore re etse yang go avoid COVID-19. Ha e fetsa go ba teng e bolele most of the South African ba bangata. After that, minister o tlhageletse e le gore o jele tšhelete ya ba go a fela gona mo feletse motho re batla o tseba re NHI yone ka se etse ntho e ntsweng ke nako ele ka nako ya COVID mo ntshwana mo World Health Organization a se lantsha di billion tsa di tšhelete then be di fela mo moyeng fela. Thank you.
Thank you. Number 14.
Molweni, igama lam ndinguNozuko Uyawa, a community member and an activist. We welcome the presentation and I'm here to support the NHI. Firstly, with section 5, where it says everyone will be required to register with the nearest accredited service provider or health establishment using biometrics and such other information as required, including fingerprints, photographs, ID card, and proof of residence. This will help us because some of us, we come to Gauteng coming from other provinces. When I go back home in the Eastern Cape, I won't be required to go through my medical information because it will be on the system. Because kuzobe kusetshenziswa i-biometrics ne-ID yam izoreleasa yonke information about my health. Now I don't have to go and say this is the issue. Each and every doctor that I go to will be able to follow my health system. I support it again because of section 6 and 8, where it says NHI will ensure that users of healthcare services have the right to access quality healthcare services free at the point of care from an accredited healthcare service provider or health establishment upon providing proof of identity and fund. You know, government wethu is subsidizing both private and the public sector. But you'll find that the public sector is more overloaded because it's servicing about 85% of the community, while the private sector is servicing maybe around 15%. And the private sector is making more money because also people are paying the medical aids. And the government, ithwala umthwalo omkhulu kune private sector. But imali ebezifumana ku government, it's equal. And there are many people that are servicing the public sector. Ndiphinde ndiyisupport i-NHI because ku section 33, once NHI has fully implemented, medical aid schemes may only offer complementary cover to services that are not covered by NHI fund. Siyayibulela lento ngoba nathi singabanye sisebenza siz afford medical aids, but ngoku ubuntu sebuphelile asisakwazi ukusa abantu abezi family members zethu, extended families, because when you add more people in the medical aid nemali oyibhatalayo iyenyuka. So at least this will help us because medical aid now will only cover what is not covered by the NHI. And lastly, one of the important sections that I like is section 57, where it says despite anything to the contrary in this act must be implemented in 2 phases. National health insurance must gradually phased in using a progressive and pragmatic approach based on financial resources and availability. And this we funda yonke if section 57. But what I like about this is implementing it in phases. Because when we implement ENHI in phases, it means also the government will have an opportunity to see where it is lacking and monitoring how far it has covered and what needs to be improved. So the phases will also assist us in monitoring the issues like even corruption and how the NHI is benefiting the people. Thank you, Chair.
Thank you very much. Number 15.
Halala NHI, halala. Halala NHI, halala. Pambili NHI, pambili. Thank you very much, Chairperson. My name is Dr. Onas Mukari. I am here on behalf of the Progressive Professionals Forum in Gauteng. Progressive Professionals Forum is a forum of doctors, pharmacists, lawyers, accountants, and other professionals. We know that there's a perception that professionals or doctors in particular don't support the bill. We are here as the Progressive Professionals Forum. We have consulted many of our members, healthcare workers who are not doctors, physiotherapists, and others. The majority of our members support the NHI. And as PPF, we support the NHI. But Chairperson, allow us to give inputs as PPF why we support the bill. We think that the bill is a solution to many of the problems that the health system has. But it's also important, Chairperson, to know where we come from. That during apartheid, we know that there was inequality. A good health care, then now in democracy, quality good health care is only for those that afford, which is the private health care, the private sector. So ENHI, when we read it, is there to equalize so that everyone have access to quality health care. And Chairperson, we think that it's a serious disservice that currently, as we speak, the public health system is servicing 85% of our population, which means that 85% of our population is almost 45 million of the 60 million people in South Africa. And the private healthcare services only 15%, which is about 15 million people. But in terms of our resources, the majority of the resources goes to the private sector than to the public sector. That's why our public sector, everyone that was talking now is complaining about the status of our healthcare. It's because it's under-resourced. So what the NHI seeks to achieve, Chairperson, it seeks to create a fund. I think it's section 9 of the bill, whereby the NHI is saying that it seeks to create a fund which will then cater for everyone, whether you are sebenza or our savings, to combine and create one pool for everyone. And we support that because in doing so, everyone else will be able to access healthcare without having to pay for it. But we think that it's important to make it practical, Chairperson. What it means is that when we are sick, Maugola at the moment, when you are sick, you can only go to the public sector, public clinic or public hospital. But what the bill is saying, the way we understand it, is that when you are sick, you can go to either a general practitioner in private or a clinic in private or public. And we think that's what it means. The only thing that it requires us to do is to register. When you register to your GP, the GP next to you, when you are sick,
you'll go to your GP. So izenzani ukuthi the queues that are long, akithi manje all of us siya ku public clinic. So what will happen with the NHI, the way we understand it, is that when you are sick, then you will have a choice. Kuthi hayi ithinya ku public clinic or ngiyobona a private doctor. When you go to the private doctor, NHI will pay for you. Then ma uya ku doctor, doctor aku refer to a hospital. Angaku refer to a private hospital or a public hospital, and NHI will pay for you. So we think it's a revolution, Chairperson, that the NHI will have everyone to access a public or private. But the only thing we need is to register first and to be referred. I think that is section 7 that talks about AMA referrals. Meaning that Masigula, we don't have to go to the hospital first. You go to the private doctor or you go to the clinic, and then the doctor will refer you to the hospital. When he refer you to Mediclinic or to Mill Park, NHI will pay. And we think that it benefits our people. The next one, Chairperson, that we think as PPF we have to talk about is the role of medical aids, which is section 33. Section 33 bill says that once NHI has been fully implemented, medical schemes may only cover complementary services or not services covered by the NHI. And we think that all it's saying is that as NHI it gets implemented, those services that we get because cinema medical aid, because now makune NHI uzobana medical aid card yakho. The NHI is your medical aid. So when you are sick, you go to a private doctor, you go to a private hospital. There won't be any need for a medical aid. So with time, most people will get out of medical aid because medical aid cannot cover anything that is covered by NHI. And lastly is the implementation. Section 57 talks about implementation. Our understanding, Chairperson, is that NHI won't be an overnight implementation. We won't just wake up at next month kune NHI. When we read section 57, what it is saying is that it will be implemented in 2 phases. The first phase, it will cover the vulnerable people. Meaning that when it's implemented, first it will, yeah. And Chairperson, it's important for me to indicate that currently, women, pregnant women, children, they do not pay when they go to the public institutions. So what it is saying in section 57 is that in the first phase, vulnerable people, women, children, elderly, and the disabled people. So it means that a budget will only be allocated for that category. And it even says from 2024 to 2026. So we think that is implementable. So it will be the first phase of implementation. Kuzofana ne vaccine. You remember vaccine when it was implemented? It came in stages. First, but comorbidities, elderly, and so on. Ultimately, we're all covered. So we think section 57 is very clear. It says in the first 3 years, the vulnerable people will be covered. After 3 years, the next 3 years, resources will be allocated for new additional services. Kushagut in the first 3 years, it will be only those categories, but it will be NHI. And then in small phases, ultimately, everyone will be covered. So we don't need 500 billion to implement NHI. The only thing we need is that those children and pregnant women and women in general and elderly, now they can go to a private hospital. When they go to a private hospital, they will be paid for. But if I'm not a part of the vulnerable, I cannot in the first 3 years. Because money will only be allocated for that group only. So when they are all covered, then another group will come in. We thank you, Chairperson, and we support the bill. Viva NHI, viva!
At the back, coming this way, and do not make noise, because now is time for responses. I dislike when a person with a medical aid, the medical aid is exhausted, and that person is dumped to the government. That is very, very wrong. Why must I have a medical aid then when I need care and they say you are exhausted, we don't want to deal with you anymore? Why? People's houses are sold so that they could get money for for treatment. So medical aid is very unfair to dump me when I've been paying and the allocation per annum is finished. Then they say, you will see how to finish. That is unfair. Tembi and the team, please let people come in. Then you start giving everybody don't give people that are outside. Give people that are seated and give them their food. Then we're going to get responses. I'm going to start by asking Mr. Musenuri, representing Gauteng Department of Health, to respond to the issues. And then I will ask National Department of Health if Mr. Musenuri is accompanied by officials. I only need responses based on NHI. On other issues that are not NHI related, you can come here and we will show you who to talk to, so that we're not going to be too long, because there is already people who are hungry here. In our committee, we don't keep people hungry. That is why, because we said between 11 and 2, and it is 2 o'clock, food must be given to people seated. Come on, meeting. Baba Lincoln, please don't give them food. Can I request the team to work together and give everybody food that are seated, starting from the back? So I'm going to now request Mr. Musenuri, on behalf of Gauteng Department of Health, to respond to issues that were raised regarding NHI.
There were so many questions that were asked, but most of the questions were input actually. Nearly the comments, nearly the input that we have noted. So I would like to give our acting COO just to respond to some critical issues that have been raised. Ntate Magoro, just to answer some of these issues.
Thank you very much, Chair. Dumelang. Ke a tshepa le a kgona ho nkutlwa ka mo morao. Thank you very much, Chair. I'm going to assist and provide some responses in relation to the questions that were asked. But I think Bahaeso, it's very, very important to rethalohanye or ha re bulela ka National Health Insurance. Re bulela ka a fund e tlo kgonang o ira hore re be le ditshebeletso tsa rona tsa health ko government, in our clinics, in our hospitals as we know them, isn't it? And hape re ska lebala or on top of that, una le private sector, and private sector mo Sidibeng liko West Rand. It is in the form of private hospitals. Le a di tseba di private hospitals mo. It is also in the form of general practitioners or GPs. Le a ba tseba ba ona liko motseng re shumisana le bona. So Lazarus o boletse ka ore re na le problem li infrastructure ya rona. Ising mo Sidibeng fela, but liko West Rand, liko hungwe in the province. Accountant wa rona, akisatsibo ufeletse ko kae. There was an accountant here. accountant o boletse hore minister o ntse a re na 200 billion ya ho lokisa infrastructure. So hona jwale ho na le mme o mongwe o boletse ka Bophelong clinic. A re Bophelong e a tlala, right? So ha Bophelong e tletse under the National Health Insurance, le tla kgona hore le ye even to private GPs selling haufi le Bophelong. So we don't have to be all crammed to go Bophelong. So it's basically what the bill is saying. So the Department of Health at the moment, more Gauteng, infrastructure is currently being attended to, but pace e re tsamayang ka yona ai fast enough. Renali Zone 17 clinic, le a e tseba. It's state-of-the-art clinic. It's an example of how we want health infrastructure in the public service to look like here in Sidibeng. Renali bo Randfontein, le bo Kokos.
Hello, acting Solanyan Pap. Dijo ko morago. Ne re kopa ska lwana le noise ya dijo, tima e papa. Ne re kopa ska bakana le noise ya dijo. Is it that one off? Thank you. Ne re kopa dijo di fiwe hantle with silence. That is why chair a itse re kopa batho ba dule mo fatshe. So there is proper coordination of the food. But if se re bakisana le noise ya dijo, a re no fumana di responses se re di batlang. So ne re kopa order, distribution will be done properly. Everybody that is seated will get the food. So let us not move, let us not even fight for the food. Thank you very much.
Thank you very much. Arisa tswela pele. NHI na hari implementer. We are not going to wake up one day, Rabarnali NHI e feletseng. It's going to be implemented in a phased-in approach. Horauri, Rita Thoma, as Dr. Waruna Atalusite, right through to 2028. Rinse Rilika Mohari re-implement. There is the chair from the Board of Healthcare Funders, Aksati Burusali Onana. Chair, are you still here? He's not here. Okay, he's gone. But what I can say, just to provide a response to many questions that he has asked earlier. NHI bill, asi implementation plan. A rebulelika implementation plan ona jwale. We are just talking about the bill. So ha bulela ka hore private sector institutions, those that want to participate, di tshwanetse di register, and they must also be known by the National Treasury. There is still going to be a detailed plan which talks about registration. Ubuletse hape ka the use of an unabridged birth certificate. We are not able to go into more details in relation to that in the bill itself. So the bill is only providing guidance in relation to how such things will be implemented. So it's very, very important, Bahaeshu. Ari utlushiseng uro na jwale mo ari buleli ka implementation plan, ari bulela ka bill. Huna li information e re buletseng yona mabapi le taba ya tjhelete. Uri, do we have enough money to implement the national health insurance? I think ki yona ntho e ke tshwantse ke tlhalose before ke nna ke ya ko tlase, then Remusonogi o tla bulela ka tse setseng. Bahaeshu, what we need to understand at the moment, Kiori, tjhelete e re berekisang hona jwale as it is, it's already too much given what we are getting in terms of healthcare services for the general public ya South Africa. That's why Luna naling medical aids. The doctors are Luna. They are keeping you in those private hospitals longer than necessary, because they want you to pay much more than what is required. So what we are saying, we have seen unali this over-servicing in the private sector. Kauri, how do you explain a situation ya mutu onang ko deep slot? Deep slot ki tlalwana le a itseba. Utsamaya afita the private hospitals tse fetang 10 a tla ko Tembisa ko Ekurhuleni. So under the national health insurance, such things will not happen. Ha o tletse ko Bophelong, you need to be assisted by a private facility that is available in the form of private GP or any other hospital which can assist you, rather than hore o ye ko Sebokeng ko kgole. Ke kopa o bolela ka tjhelete hanyane before ke nna ko fatshe. Now, ha re lebeletse national health insurance, tjhelete ya hona jwale e re berekisang, it's estimated to be between 8.2 to 8.8% of the GDP. Ke a tseba hore ke bolela ntho e sa tlhalohang e leng a bit difficult hore batho ba bangwe ba ka kgona ho itshwara, but ntho e leng hona ke ya hore already there is an amount of money that we are currently using, but we are not using it effectively, accountant wa rona. We need to start there, and what we are saying is that le highly 8.8% ya GDP which is being used, we are not expecting or we will be spending much more than that 8.8%. And at a later stage, if you are interested, we can break down the numbers and even indicate the source of funding that are currently available in as far as that is concerned. Ya mafelelo ke ya the foreign nationals, ke kopa o itlhalose before ke nna ke dula ko fatshe. Batho ba isho, hona le batho ba bangwe ba sa tshwaneng le rona, when we see them we just think they are foreign nationals, akere? But under the national health insurance, the beneficiaries under the NHI, it over South African citizens, akere? It laba le bana ba bona, it laba di permanent residents. Hona le batho ba bangwe re a kgona ba bona hore ba tswa ko Zimbabwe, ba tswa ko kae ne, but ba bangwe they are permanent residents here in South Africa. Ora hore le bona ba irang ba qualify under NHI le ha ba sa kgone ho bolela Sesotho. The refugees, le designated foreign nationals, le bona ba tla kgona ho kreya health services under the national health insurance. However, hona le another category ya di foreigners who are regarded as asylum seekers or the illegal immigrants, le di foreigners that do not have travel insurance. So those ones are not going to get a full cover ya national health insurance, but o kreya fela emergency medical services so that they can be able to be stabilized. If ba lwala ba na le a notifiable medical condition ya o tshwana le malaria, we will have to treat them. And ya mafelelo ke ya hore everyone who will be coming into our country as a foreigner will be required to buy medical insurance so that they can be treated under the national health insurance. Thank you very much, Remson. You can deal with what.
We'll give the national just to cover the issue of traditional healers.
Okay, thank you very much. I'm going to answer the issue relating to traditional health practitioners. There was a question that how will the NHI or how will they benefit from NHI as health practitioners? We are currently working on the regulation that are going to be promulgated that will enable all the traditional health practitioners to register the same way as the SPCSA registered medical doctors. The traditional health council practice will then register them and give them their own certificate. Once they are registered and given a certificate, then they will be part of the mainstream health system. They can then make referral to a health establishment. So the NHI is only dealing with the funding of the health. It's not dealing with the governance of the health professions. So the Traditional Practitioners Act is the one that deals with the issues that were raised by Gogo and also another one. So NHI is not dealing directly with them, but once they are registered as health practitioners and also accredited in terms of the NHI Act, then they will be registered as service providers, can provide services and can then claim from the fund. Thanks.
Re a leboha, re na le representative ya rena permanent delegate ko parlamenteng, Honorable Baha. I'm going to give her a chance to say something as we are moving towards the closure of our public participation.
Thank you, Chairperson. Firstly, let me say that it's important that we are able to air our views on any legal matters that come up or any laws that the Parliament envisages, because that then gives you an opportunity to raise your views and be heard. That's the intention of this meeting. Secondly, the NHI envisages a standardized healthcare system wherein everyone, rich and poor, rural and urban, can receive the same level of quality health care. That's the bottom line about on the NHI. Now, I know some of you felt that you are being cut off when you went on and on. But remember, when you have a long submission to make, you can submit it directly to Parliament. And the email address is going to be given here, where you can send through your views. So I'm directly referring to Usisi, who felt she was being cut off. I guess we have time constraints, and therefore when you go longer than others, you then have to make a written submission, and that will be considered. So I'm saying not only to her, if anyone feels that there are issues that needs to be considered, make a written submission, and those will be taken into account. And the negotiation mandates. Remember, when we are done with all the public hearings, there will be a submission by Gauteng that says this is our view on this bill. And that then comes to me in the NCOP, and I stand up and read it there, and then it goes ahead. If Gauteng says no, we don't want it, that's what I will say. If Gauteng says that's what we are for, that's what I will say there as well. The closing date for written submissions is the 15th of September. By the 15th of September, make sure that your submission has gone through, then it will be considered. The final mandate, where we say that Gauteng accepts or agrees to this bill, will be on the 31st of October this year. So, Chairperson, I thought that let me make that input and that clarification. But I'm happy that people were able to raise their views. Whether they were correct or not, but you were able to stand up and say what you think is your view according to this bill. Other things that are not related to the bill, people have been directed to whom they must speak to, and those will be taken into account. So in those words, Chair, I want to thank everybody who's here, because at least it means our democracy is working. Remember, in the past, no one would come to you with any bill. The bills will go through, you will hear that this is the Group Areas Act and it's been agreed to, and you had nothing to say about it. Take this opportunity, use it, raise your views. Let this be taken into account in Parliament when we finalize all the bills that we have to deal with. And in that way, you would have contributed in our democracy in this country. So Chairperson, I think that for me, I'm happy with how the meeting went. And yeah, we'll take it from there and go to other areas and do the same. Thank you so much.
Thank you very much, Honorable Baha. for your progressive input. If there are still those who want to write something, you are welcome to write and bring it here. There is the submission email written there. Please write it down, then you can, sorry, hello. You can start from that row, the third row. Row number 3. We are kwa. Thank you, ne? Re a leboha. Let me take this opportunity to thank you all. You are supporting the bill, however, you want certain things to be corrected. Again, you want infrastructure to be good. Where the clinic is not there, you want the clinic to be there. You want problems to be resolved before the implementation. And I think you were listening. Barile, I want implementation quick. Again, maralina, le supporta bili, maralina karulukisiwe mole mola. Again, akili misrepresent kelina. Le repilie le itabela, maragulukisiwe mole mola. Again. The input is already very important. Already late. Le renare au prepare gore re tlile mo setšhaba sa Sedibeng le setšhaba sa ko Westland ba bolela gore ya re shapo ka pili mara lukisang 1 2 3 akere I'm not misrepresenting you ke a le leboha meeting wa rena o felela mara okay in our midst I just want to ask the deputy speaker o tlile re fitile in terms of introduction our deputy speaker in the legislature just to wave. Can you wave, deputy speaker? You want to say something? No, you are welcome.
Thank you very much. I'm being forced here to speak. Nana ki re ke tlo thega program mara ra leboga setšhaba sa ko Western le ko Sedibeng re le fe gore le re bone and le re fe opportunity. Thank you very much. And importantly, thanks for le support yona bill yona It will not be it will not come into law without your support. And I can't need let's fix those things, the concerns talona that you raised. But otherwise, everything it's a maile handle. This is in our interest. Hori healthcare be accessible to everybody. So kiska isinya kiska sinya ndwentle. Kile bugile le hore ke gono re ke le address le ene ke sa plan mara ke bo le bogwa student committee re a copy from here with the input. Thank you very much. Have a wonderful weekend ahead. Thank you.
Thank you very much. Before Lisa Maya, I told you we track ane. Don't go with it. What track law enforcement agencies. So remember hore ibereka mo fela ikase bereke le he o ka ya le yona hae. Itshwanetse ibereke mo. Leave it here. You are all going to be given food. Please do not leave without getting your food. Let me thank you very much and travel safely to your respective homes. Thank you.